Good afternoon, everyone. A very warm welcome to everyone. I feel extremely glad to welcome everyone to this much awaited conference. It gives me immense pleasure to be standing in front of you all. That is like amongst the most esteemed personalities over here. Thank you so much. So, shall we start? Yes. Uh, so, we'll start with the lamp lighting ceremony. So for that, I would like to invite our organizers, Dr. Vijay Devanhalli, Dr. Tanay Shah, Dr. Mansi Shah, and our chief guest, Dr. Christian Jackies. Please welcome, sir. I would like to invite Dr. Vijay Devanhalli to speak few words. Thank you, sir.
Good afternoon, ladies and gentlemen. It's a great pleasure to be here at the Statue of Unity, the world's largest statue of Sardar Patel, was one of the major architects of independent India. So the program was devised in such a way. The compeer asked me to speak a few words, but I'll go beyond what has been allotted to me because I am the organizing chairman and I have that flexibility to speak on and on. But when the program was devised, this was initially we thought that we will talk about surgeons and early breast cancer. Two categories, HER2 positive early breast cancer, where the use of pertuzumab with trastuzumab and the combination of Fesgo has played a very major role. We also had a 3-hour session on triple negative breast cancer, EBC, TNBC, EBC, where the use of pembrolizumab is now gradually, the role of pembrolizumab is upcoming and we are certainly using it in our own practice. So that is how the program was devised. But we also wanted to make it very interesting for the surgical oncologists, and therefore we have some of the country's best oncoplastic surgeons, Navneet, Sanjit, Gaurav, and many others who are very personal friends who will also talk about some oncoplastic techniques, and that's part of the program to make it very interesting. We are truly privileged to have the presence of Professor Christian Jackies all the way from Germany. I hope he will really enjoy his stay. There are a lot of residents in the audience, and I was talking to him today morning when he said that one thing he hates are silent audiences. So I would request everyone of you to sit in the front row. Please ask him questions. He is one of the world's leading authorities from Germany. He will be introduced by Dr. Mansi in a short time. But whenever he comes, this is part of my speech as the organizing chairman. But feel free to ask any of the, even Sanjit, Navneet, whoever are going to be the next. Make it into a very interactive session. You have such a lot of brilliant speakers. They have consented to come all the way from all over India, actually, from Hyderabad. We have a large audience from Bangalore, Chennai, Delhi, Kolkata, Lucknow, Bombay, and it's really our pleasure. Please interact. Ahmedabad, of course, we have two people from the Gujarat Cancer and Research Institutes. So it's going to be a very interesting 1.5 day program. I'll come back and talk about today's events, or probably one of the secretaries can talk about it as we go on. I'll now hand it over to the scientific chair. We also are running this program online. So currently about 120 people are watching this program online, because it was very difficult for everyone to travel at this particular time to this part of the country, a little away from the main urban areas, I would say. So we have put this program online, and about 120 people are online and watching this particular program. Thank you once again.
Okay, so now let's start with the first session. I would like to invite the chairpersons of this session, Dr. Mansi Shah. She is the consultant medical oncologist at HCG Cancer Center, Ahmedabad, and Dr. Abhishek Jain. He is the consultant oncosurgeon at Shelby Hospitals, Ahmedabad.
Hello, very good afternoon to all of you. Thank you to the entire organizing committee for having us here. And it's really a wonderful venue to start with. It's actually the pride of our country, the Statue of Unity. So for the first talk, I would like to invite Dr. Navneet Kaur from New Delhi, and she'll be talking on minimally invasive approaches in breast cancer surgery, the latest updates in the techniques. Welcome, ma'am.
Thank you, chairpersons. Very good afternoon to all. I bring greetings from Capital Region, Delhi. I am a professor of surgery in a medical college in Delhi region. And first of all, I would like to extend my thanks to the organizing committee and Dr. Vijay for hosting me at such a wonderful, exotic location for a conference. And more than that, I think I would like to thank him for asking me to speak on a topic which so far I was very um, casual in thought or dismissive about this being just a propaganda surgery. Why do we need minimal access surgery for something which is as superficial as breast, something which is as less morbid as breast? And these titles or papers I will just skip through, thinking they are just propaganda, and I think there are no takers in the real world for that. But when I looked into literature, then I realized it is not always good to kind of ignore an innovation or just dismiss it as propaganda. Everything brings to the table something valuable, and we must at least look at the evidence before accepting or rejecting a new technology that has been introduced into the market. So I'll be talking about minimally invasive approaches in breast cancer surgery, updates and techniques. So whenever we say minimal access, I'm sure everybody thinks of minimal access surgery, laparoscopic surgery, endoscopic surgery, now robotic surgery, and its role in breast cancer. So that is something, I think, as I said in the first go, it seems very superfluous, not required, but yes, it would have its own merits, and we should look into that. So we have seen over the last 4-5 decades how the treatment of breast cancer has transformed. As I believe quite a few of you are surgical oncologists, so I don't have to dwell much upon that. Mastectomy was a gold standard for almost 100 years. Before the trend of de-escalation started with modification or radical mastectomy. So modified radical mastectomy introduced in 1970s, 80s was accepted. Then 1 or 2 decades down the line, breast conservation was introduced and enough evidence was produced to say it is safe. Then for better cosmetic outcomes, we combined plastic surgical techniques with oncological procedures, and we developed oncoplastic breast surgery. And I was one of the first ones who got trained in that, say about 20 years back. and one of the first ones to come back and start practicing oncoplastic breast surgery. So I have a 20-year experience, and this has been accepted and so widely practiced that every breast surgeon is now supposed to be and is an expert in oncoplastic breast surgery. So what is the need further to become more complex, looking for, but then I think two factors drive this: the pursuit of excellence and also maybe the innovation. So there was a ongoing demand for further improving the results, make it even more minimally invasive, preserve the organ as much as possible, which probably has given thirst to the development of these minimally invasive approaches. So it is a term which is coined for surgery, which is going to cause less trauma. So we can understand for a pelvic surgery or for a esophageal surgery, if we have to make a thoracotomy and a laparotomy and a neck incision, it is extensive. But if the same can be achieved through laparoscopic means with few ports, that means definitely it is a very well offered option and very minimally invasive. But it is not really always minimally invasive if we look at the amount of dissection that may be required. And this is especially true for superficial organs. Even for thyroid, there is a lot of interest in minimally invasive thyroid surgery. But if you look at the procedure with entrance from axilla or over the breast area or intraoral, that all seems so very invasive. So I think there is a kind of a distinction to be drawn between what is actually minimally invasive and what should be called minimal access as the more appropriate term, and still have those procedures which are truly minimally invasive as well. So I will dwell upon that. When we say minimal access, incision is smaller or hidden as compared to the conventional approach, right? But the dissection and disruption of breast parenchyma is far more extensive. For example, if we have to reach a tumor in the, say, lower inner quadrant, we can very well use an intramammary incision and do whatever we want with the excess fat, reshaping and whatever. But if the same thing is to be done through an endoscopic approach, you enter through axilla, go over the entire breast, dig into the middle inner quadrant, and then do the required procedure on the breast primary. So we can have this distinction between minimal access and minimally invasive. So I would first talk about minimal access breast surgery, where the access is smaller, but dissection is definitely much more extensive. And it falls in the two broad categories. One is endoscope-assisted breast cancer surgery, and robotic is just the refinement or further innovation in the field of endoscopic surgery. And then there can be further subcategories based on whether insufflation is used to create the space or we are using retractors, and what kind of optics which are available. So super high definition to 3D immersive experiences. I think this is an area which will have more innovations beyond our imagination in the times to come, and we only have to just wait and watch what's happening. And it started happening almost 2 decades back. So first case series of endoscopic breast conservation surgery and endoscopic nipple sparing mastectomy were done in 2001 and 2002, and they demonstrate first the feasibility, that it can be done and it offers the better outcomes. Then over the next 2 decades, just like for breast conservation, we had a lot of speculation, then a lot of data collection, prospective studies, which said it is okay, it is oncological safe. Same has been the case happening in the field of minimal invasive surgery as well, minimal access. And in the next 2 decades, multiple studies showed that they are oncologically also safe and acceptable. And robotics started about, say, 10 years or 8-9 years back. So it is the most recent entrant, but again, there is further innovation that is going to be happening. So is everybody a candidate for robotic or endoscopic breast surgery? I think that's the question which is pertinent, and even at the end of the presentation, this question will remain just as pertinent. There are currently almost the same indications that we can do for conventional breast surgery. So it can be offered for early breast cancer, where we can do breast conservation. It same can be done by these minimal access approaches. And endoscopic nipple sparing mastectomy for high risk lesions for DCIS, wherever there is indication to do a mastectomy, it can be done endoscopically as well. And now even immediate breast reconstruction, implant-based was, I think, done at the same time when the mastectomy was being done. Over the years, harvesting of autologous tissue, latissimus dorsi, omentum, and even the tram they all are being harvested endoscopically and being used to reconstruct the breast. So these remain the indications. Probably patient selection is what is important, and I think I'll highlight that during the course of presentation. So what are the minimal access techniques? Broadly, we heard that it is endoscopic and robotic. Incisions made are in very concealed positions, so it is either in the axilla or in the anterior axillary line or lateral memory, this thing fold. And surgery is, when it was started, it was done through 2 ports. So there would be 1 port near the areola, NAC, and 1 port in the axilla, and then resection was done with the help of retractors. Subsequently, as experience was gained, so it is now a single port, and one can do tumescence by injecting saline into the subcutaneous space. Then the periphery of the dissection is marked with blue dye so that they know endoscopically this is the extent of dissection that is required. Then this is a single port with a camera and 2 working hands, which is introduced through here. A plane is created. While at the NAC, additional tissue can be taken and sent for frozen to ensure that NAC is not involved. Then do the dissection all around. Go behind the breast tissue into the prepectoral space. Create the space, get the tumor out, and then put an implant to reconstruct at the same sitting. So this is how endoscopic procedure gets carried out. And there have been further innovations from retraction with retractors to insufflation, and from 2 or 3 incisions to a single incision, which is also used for sentinel node biopsy, and if required, little modification even for harvesting of the latissimus dorsi muscle. Complications more or less have been thus similar. Rather, they say there is less reports of nipple areola necrosis with this approach. So this is a patient who has, this is a surgeon from Taiwan who has been actively doing innovation and development in this area with 2 decades of experience. He has published his studies and he has shared a lot of material on net with videos and other things. So I can't pronounce his name very correctly, but then this is how the same thing is being done in a patient with a very acceptable cosmetic outcome and minimal excess. Even axillary dissection can be done by axilloscopy or axillary surgery. Sentinel node is as simple as just picking up the sentinel node guided by any of these modern techniques. But if we have to do full dissection, even that has been reported as a viable technique. They first do liposuction, so all the excess fat from the breast is sucked out, from the axillary area is sucked out, and then whatever is left of nodes and lymphatics is carefully dissected under direct vision. And then that's how it comes out piecemeal, not as an en bloc dissection, but still it is a feasible and a possible strategy. And the same thing when it is done through a robotic platform. So here instead of the surgeon, it is replaced by the robot, same kind of a port. Now the person is sitting here at the console and similar procedure is being carried out. So it is just a kind of further development of the same minimal access approach. Advantage of robotic over endoscopic is you have better visualization, and surgeon is less tired because he is sitting and operating, but the problems are prolonged operative time, increased cost, as well as availability, requirement of robotic platforms wherever this has to be done. And there would be future developments in the field, like we are going to see a single port robotic platform which is being developed by Da Vinci, which is already in the market. So a single port and freedom of 360 dissection with robotic arms, sitting at a console and doing a surgery is going to be probably a way forwards. Again, there is a society which is set up. International Conference of Endoscopic and Robotic Breast Surgeons was held in Taiwan. They are going to have another one in 24 with cadaveric workshops. There is a consensus statement on robotic mastectomy which covers domains like indications, contraindications. So there is a lot of development in the area with people who are interested and have developed the required skills. And there's always literature to check the authenticity of the claim. So they have published 10-year experience, have shown how the technique progressed over the years. But one thing I would like to comment here is if you see all these procedures, these are done in patients who have cup size A breast. So these are not the kind of breasts we see either in Indian population, South Asian population, or maybe in the West. So this is probably is the reason why this is mostly developed, practiced in the Asian countries like Taiwan, China, Japan. They are the pioneers in the field where patients are more suitable for this kind of a surgery. But still, I would say very soon we will have reports being published from everywhere as we gain more confidence and access to the technology. Now coming to the minimally invasive breast cancer surgery. And if we talk about the options, these were already being used for benign breast conditions. So for fibroadenomas, percutaneous ablative techniques, whether by using radiofrequency ablation, whether using cryoablation, microwave, or even that vacuum-assisted excision, they all were very well accepted as viable options when somebody was wanting to avoid a surgery. And then the same has been now extended into the field of small cancers. And vacuum-assisted breast biopsy is an accepted modality for high-risk breast lesions, which are not yet malignant, but they definitely are high risk, and we need a more clear margin of resection compared to a benign condition like fibroadenoma. But they too have been tested and evolved and are evolving, and we are getting to see the reports where there will be select indications. So cryoablation means freezing that area which is to be taken out, be it a malignant or a benign tumor. And it is done with a cryoprobe. Temperatures are to the tune of -40. And the technique is detailed. You have to localize the tumor based on any of the imaging investigations. They are mostly done based on ultrasound and CT, but even MRI is also commonly used. And usually very selected small lesions. So early breast cancers, maybe for patients who are refusing surgery or cannot undergo surgery, patients who have metastatic disease and a very small breast primary, they can be offered such kind of this procedure. And after the procedure, they are again followed up by repeated imaging. And then if the tumor disappears completely, it's fine. Otherwise, it can be combined with an excision procedure. So this is how this gets done. So under the guidance of ultrasound probe, this is the area which is targeted. There is a kind of a, like we take out a gross margin of 1 centimeter during dissection, they create a ball of ice of 1 centimeter beyond the tumor in multiple cycles of freezing and thawing. So it's about a OPD procedure done in half an hour to 1 hour time. And this is to be followed up by imaging. So this is the ice ball created post procedure. Then this is after 6 months follow up, very small residual tumor. This can be excised by any of the means of needle guided excision, and maybe if everything is clear, this can be the end of the procedure. And evidence to date has been like mostly it is useful for less than 1 centimeter lesions, maybe 1.5, but for larger lesions, it may not be feasible to get a clear margin. Then the vacuum assisted surgical excision is also being tested, whether it can be done under a mammographic stereotactic guidance or a MRI guidance or an ultrasound guidance. So this can be just excised with multiple cores looking like this. And the margin assessment is the tricky issue, which has to be done subsequently by some additional percutaneous biopsy. This is the BART's new machine, which is very portable, handheld, easy to handle kind of a machine. And the evidence so far is like there is a mixed kind of a picture. Some people have reported like this one says that none of the small invasive cancers were completely excised, and VAE under US guidance is not a reliable method. Whereas another report, this is from Italy, they had a reasonably high success rate and they recommended for smaller lesions. So these are techniques probably which are going to be, they will be refined further, maybe suitable for selected kind of patients. So what do we take away from the presentation that I have made? Is it going to be an era of minimal access surgery, or it is another technique in the armamentarium of breast surgeons, which is useful for select indications? So let's not get be like overexcited about something till the time it has proven its worth and feasibility and cost effectiveness in the long run. So from this thing of initial approach towards minimal access being totally superfluous to something which has merit and should be integrated, so surgeons should learn these techniques if possible and keep it as an option which is to be offered to a appropriate candidate. So I would end by saying thank you and never say no to adventures. Always say yes. Otherwise, you will lead not just a dull life, maybe you will left out in the competition because this is the times of lot of propaganda and hype and patients' demand, which is generated through a lot of, I would say, social media. People may come and want and ask for robotic surgery. And if you say that I don't think it is worth it or I don't do it, then they will go for somebody else rather than be convinced that it is just the extra hype. So I think that's all I would like to make in this presentation. Any questions are welcome. And I think I finished also on time.
Yeah, thank you, madam. It was a wonderful presentation, and you have presented something which was really unthinkable few years ago. And sir, are we allowed to take questions right now?
Yeah. No problem.
So, any questions from the audiences? Dr. Krishan, one question. Madam, what is your experience with cryoablation? Are you routinely doing it for early breast cancers?
Yeah.
You can use
You
this.
are asking me this question? Yeah. So I haven't used any of these technologies myself at all. There is no access. In fact, I work in a public hospital. So next 10 years of my career, as far as I'm in job, I'm not going to have access to any of this. But what advice can I give to a patient? If somebody comes and asks me, I think I should at least be a well-informed breast surgeon who knows a good orthoplastic surgery job, but at the same time can tell somebody if you have an option, go for it.
Sir, your experience.
So thank you so much for bringing up all these details. If I recall it correctly, you were just showing very thin women.
Yeah.
So the question of the three-dimensional space, if you do not have this body mass index, do you think the techniques are as safe?
So I would say, yes, it is very appropriate for, say, breast size, which is very small, which is classically that of Asian women. And this is, I think I did say in my talk also, that this is why these countries have taken the initiative and developed the technique so much. But when you come to do it, it is not that it is not possible. It may take more time. It may have lesser indications because there are many women who are thin. So my, again, message was to use it for select patients who are the good candidates. They have small breast size. They have to have their breast removed. They can't have conservation because if you do a lumpectomy in a small size breast, there's hardly left to preserve the body surface, body image. So it will be useful mainly for small breasted patients, but we don't know. Innovations is, only time will tell how far we improve the technique and do it.
No, I fully buy this. But just one remark, axillary surgery endoscopic is a very old story, more than 50, 20 years ago. So now we are living more or less in these selected cases in the time of sentinel lymph node procedures. So I would guess the damage would be the same thing with a small incision and a good visualization. Then the port itself is not an easy one if you have the single port approach. But we're going to see how this emerges.
Right.
My question is, if you're doing a laparoscopic or robotic assisted, we don't talk about costs. If you do this as a technique, how you control the remaining subcutaneous tissue in the risk reduction surgery?
So I think few things that they do routinely, which I looked at the steps of the procedure, is to create a space by tumescence. So they inject just in the space in which they're going to do the dissection. So skins and a very little bit of subcutaneous fat. So keeping a flap thickness of maybe 5 to 8 mm, and then inject in the space underneath. And when they are doing laparoscopic surgery with insufflation, first of all, I think when they're inserting the port, because I do general minimal access surgery. So when you are inserting the port into a space which is not actually there, you have to create, right? So like as we do in laparoscopic hernia repair surgery, we go into a space which is not there, pre-peritoneal.
So I think the risk will remain the same whether you do a laparoscopic, robotic or open in a risk reducing mastectomy of being in the correct plane, removing the appropriate amount of breast tissue in order to prevent any complication, and at the same time leaving behind any breast tissue on the breast flap, which is the whole purpose of doing the risk reducing. If I may ask you a question, how many patients of yours accept reconstruction? The challenge in India is less than 10%. We have Dr. Gaurav Agrawal and Dr. Ashutosh Mishra from Delhi and Lucknow respectively. So the number of people who accept reconstruction is very small. And therefore, a skin sparing mastectomy really doesn't make a huge difference in their so we don't do a lot of reconstruction, basically. Whether it is implant based or tissue based, most patients undergo a mastectomy, period.
So I mean, the good question is that we see more and more data that in young women around the world, a simple mastectomy is getting a more and more accepted procedure. So reconstruction is not only a cost issue, it's an intellectual issue. And a reconstructed breast should look like a breast, should feel like a breast, and should be like a breast for follow-up. So if one of these is not working, it was not a good option for the patient to do the reconstruction. And I guess that it's not the topic of your presentation, but in the neoadjuvant setting, you have almost 6 or 8 months to consider with your patient in terms of counseling the best technique. And the question I don't ask, but now I ask you, if you do your prepectoral implant and you don't have any pocket, and you have this very very small skin layer, so then the question is, number one, the jumping breast due to the intact pectoralis muscle. And the other issue is if you have capsule contraction, if you've seen that on a long follow-up, because I have not, but I guess you can do it easily to put in whatever pocket for the
So I
implant.
think placing the implant under skin is not done anymore. It is always subpectoral. So it is into the either Brexon-like reconstruction is done, or implant is put behind the pectoral muscle. It may be full pocket or partial muscle pocket. Nobody places the implant under the skin. Even with that, the capsular contracture is a significant issue. And I saw when I was training almost 30 to 40% patients coming back for capsular contracture and wanting an implant replacement. So that gets done because now radiation therapy has become even more integral part of the breast cancer care. So RT and its induced complications are definitely there. So I think demand or requirement is gone up in every direction. We have a lot of young breast cancers. We have a lot of patients who are genetically prone and we are able to identify the risk. So they are the ones to be offered a prophylactic surgery if they want to. They are the ones who can have reconstruction without radiation therapy. Maybe implant is quicker, easier on the body, so it is offered. And at the same time, with so much of downstaging and PCR rates, our need for reconstruction has gone down and a lot of oncologist surgery is being done. So this is kind of a mix of requirements and indications.
So
Thank you, madam, for the
one
wonderful
small
discussion.
comment is here. So as we have seen web-assisted biopsy, so in post-NSCT settings, we are doing right now in complete response cases, web biopsies, and comparing with the cavity excision, and we are seeing good results. So in coming time, post-NSCT complete response, definitely we can defer VCS. Secondly, there are a lot of now patients coming in for hereditary breast cancers who are asking for breast excision without scars. So there is definitely role of robotics coming in future. And secondly, in patients are asking now implant-based reconstruction a lot. In my last OPD, I've registered 7 patients for implant-based reconstruction. So time is changing.
I think yours is a referral center. So you would be getting patients who are asking for it referred to your center. So rates are that high.
Yeah.
But yes, things are changing.
Thank you, madam. Thank you for the wonderful discussion. Now, we would like to move on to our next presentation by Dr. Sanjeet Agrawal from Kolkata. And he would be talking on oncoplastic surgeries, optimizing cosmetic outcomes while ensuring oncologic safety. Welcome, sir.
Thank you very much, Dr. Vijay, scientific team, for inviting me for this talk. And it's my pleasure to be here second time in Gujarat. So my talk is oncoplastic breast surgery. So if you are a surgeon sitting in the audience, I will cover what you all are doing. So it's about how we have moved from mastectomy to BCS. What are the evidence behind mastectomy to BCS conversion and BCS to oncoplasty? So we all know that the 3 gentlemen have changed how we think for the breast cancer. One is William Halsted. He introduced the important concept that if you have breast cancer, surgical treatment is the treatment what you need to think. Before Halsted era, what the doctors were doing, they were burning the breast tumor. The treatment was to burn the breast tumor. So it was very mutilating at that time. Second gentleman, Sir Bernard Fisher, he came and introduced the concept of the less surgery. So modified radical mastectomy and breast conservation surgery. And ultimately the Milan trial was done by the Professor Veronesi about introducing breast conservation surgery in the breast surgeon armamentarium with the thinking of giving good cosmetic outcome. So what we were knowing in 2005, that mastectomy versus breast conservation surgery, as per the randomized control data, 3 randomized control data at that time with the result, with the meta-analysis, comparable local control and equal overall survival. So in 2005, our idea about breast conservation surgery was that I can do breast conservation surgery, but it will give a little bit higher rate of local recurrence with overall equivalent overall survival. So this, when we were explaining to the Indian breast cancer patient or even Indian clinician, the acceptance of the breast conservation surgery was not good in 2005 to 10, and we all know the reason that if the patient, I am saying, explaining to the patient that you may have little bit higher chance of the local recurrence, ultimately they don't want to the hassle of coming back for the local recurrence treatment, and India is still, there is a taboo for the local recurrence. And what about the cosmetic outcome in the 2005? I will come in my subsequent slide. If you will do simple wide local excision, what you will end up. So this is the data in 2015, which also changed our concept of thinking of comparison of breast conservation surgery in mastectomy. This was presented by Dr. Sabin in San Antonio Breast Cancer Congress. And what she said about Netherlands breast cancer registry data, about real world data of 37,000 patients. And she said that the 10-year survival, if you're comparing the real world data of BCS versus mastectomy, BCS survival is better than the mastectomy. And it was adjusted for the T stage and the nodal stage. So it's not that the higher stage patients are getting mastectomy, so they are having worse survival. So these data were adjusted for the T and N stage. After this presentation, there were multiple data from the different National Cancer Database Set and the Sweden Cancer Registry. So these are the 2 publications which came in the last 5 years only. And both of the publication had said that breast conservation surgery plus radiotherapy. So whenever we think for a breast conservation surgery, it's a BCT, breast conservation surgery plus radiotherapy. And the survival of the breast conservation surgery was better than mastectomy. We don't know the scientific cause. The rationale is introducing more inflammation if you're doing more mutilating surgery. So in 2021, if I look upon the data of comparing breast conservation surgery and mastectomy, the outcome is comparable local control and better overall survival. But the breast conservation surgery is not removing tumor. We need to give a equal looking breast to the opposite side, equal, the good feel and the good symmetry. So if you do simple breast conservation surgery, so in before 2010, we were doing wide local excision. So suppose there is a tumor here in the lateral part here, and you have done the wide local excision and you have not thought of the symmetry of the breast, you will end up with this type of the result. So you will do breast conservation surgery, simple wide local excision, but you will end up in a deformed breast. So there is no point of introducing breast conservation surgery with a deformed breast. This is one of our treated patient in 2010. So when I look upon after 10 years, this is the asymmetrical breast with the lateral deviation. And we really need to work upon how to improve the cosmesis if we are offering breast conservation surgery to a patient. So this person had changed the concept. So the Krishna B. Clough in 2010. So there is a seminal paper from the Krishna B. Clough. To the all resident, I will say, please read it. So he introduced the concept of the oncoplastic breast surgery with a publication which was explaining all type of the oncoplastic breast surgery. It was introduced previously also, but this is the person who has popularized this concept around the world. So he devised a classification, level 1 oncoplastic breast surgery and level 2 oncoplastic breast surgery. So what is level 1 oncoplastic breast surgery as per the Clough definition? When you are excising less than 20% of the volume. Very difficult to say that what is 20% and what is more than 20%. So what we generally follow in our clinic, that if you are removing within a quadrant, so if you are removing within a quadrant, it is level 1 oncoplastic breast surgery. But once you are going beyond the quadrant of single breast, so we divide breast in the 4 quadrant for the medical people. And if you are going beyond quadrant and if you are removing more than 20% of the volume of the breast, then you need to think for the level 2 oncoplastic breast surgery technique. Second term for the surgeon, which is very important, what type of technique we are using. It's a displacement or replacement. Displacement means if I am removing the breast tumor and I am displacing the breast tissue to cover that defect with a pillar mobilization, that's known as displacement. Second thing is the replacement. So what we do in the replacement, if I am removing the tumor and I am covering that defect with some additional tissue either from the lateral chest wall or the posterior side, so that's known as replacement. So oncoplastic breast surgery definition is 2. One is what's the volume of the excision, level 1 and level 2. One is what type of technique you are using. Are you displacing the breast tissue to cover the defect, or are you replacing somewhere else, replacing the tissue to cover the defect? So type 1 oncoplastic breast surgery, what we do in the general workforce is crescent mastopexy, round block, grissotti, and batwing and hemibatwing. So these are the important oncoplastic breast surgery we do in general, and all of the surgeons, if sitting in the audience, we need to learn this technique to give a good cosmetic outcome. So what is crescent mastopexy? So these are small crescent, So what we do, so we create a crescent type of either on periareolar region, axillary region, or inframammary line. So why we put the crescent on this side? Because we want a hidden scar. And this is the one patient, simple fibroadenoma, giant fibroadenoma. We have used crescent, and this is the final outcome after the surgery. So the periareolar scar using the crescent, removing 2 fibroadenoma, one is 5 into 5 centimeter, one is 2 into 2 centimeters. So very simple technique. The periareolar scar, use crescent, remove extra skin of the fibroadenoma, because fibroadenoma push the skin margin and give a better scar with a better symmetry. Second workhorse, what we do is round block technique. So what is round block? So as the name suggests, round block. So there are 2 rounds. So one is here, the just periareolar, and second is here. Generally used for the tumor in the upper inner quadrant or the superior quadrant. So this area we deepithelize, we cut the outer circle, we remove the tumor, mobilize the pillar, and the final outcome looks like a complete periareolar scar. Third technique we use, simple round block with the extension. So this is the round block here, and we extend it laterally, especially for the superolateral quadrant tumor, to excise the skin and excise the larger tumor. And this is the final result we get with the tennis racket incision. What is batwing? As the name suggests, the incision is like batwing. So this is used mainly for the 12 o'clock lesion, large lesion. So this is a periareolar tumor. We will remove with the skin because the skin was involved, and this is the final result with the batwing mastopexy. Similar hemi-batwing. So batwing is 2 wing, hemi-batwing is 1 wing. So this is one of my patient where tumor was in this area. So this was the mammography view, this was the USG view, this is specimen mammography, and this is the final result with the hemi-batwing. So using 1 wing of the batwing is known as hemi-batwing. So these are the small techniques, level 1 oncoplastic breast surgery, which you can use and give a better good cosmetic result. Coming to the grissotti technique. So this is for the central defect. So this is for the central tumor. If the tumor is involving NSC or close to NSC, you need to remove that whole thing. So what we do, this is a displacement type of flap. We remove this tumor. We will take a skin paddle and move to the defect to close the defect. This looks like a little bit trimmy in this outcome, but the final outcome generally breast relaxes, and this is the final outcome we achieve with the grissotti technique. So good symmetry, good breast volume, and better result. Coming to the once you have done the level 1 oncoplasty, and I feel this classification is very important because you know how you need to proceed. You should not proceed to the level 2 oncoplastic surgery to start with. You start with the level 1 and then think for the level 2 oncoplastic breast surgery. So once you are thinking for level 2 oncoplastic surgery, you need to think for the breast size, breastosis. So we do 2 type of level 2 oncoplastic breast surgery at present. One is, as I said, replacement. So suppose a small breast, large defect. So suppose there is a cup and B cup size breast, and even it's 3 into 3 centimeter tumor, if you will remove, in the small breast, you don't have anything to displace. So what you will end up, that you will end up in replacing some tissue from the lateral side and cover the defect. So chest wall perforator flap is very popular in the last 5 or 7 years. So a small breast, large defect, think for the replacement. Don't think for the displacement, but there's nothing to displace there. It's a small breast and you have removed more than one quadrant. What you will replace? What you will displace there? So the same thing, the therapeutic mammoplasty. So large breast, large defect. So suppose the lady, the patient is having large breast and you are removing 6 into 6 centimeter, but you have enough tissue to rearrange, displace the tissue and cover the defect. So that's known as therapeutic mammoplasty. So these two techniques, we say that level 2 oncoplastic breast surgery we generally use, but you need to know how to select the patient. And this is the algorithm you can follow: A cup and B cup with the non-ptotic breast, large defect, think for chest wall perforator flap, D cup and E cup size breast, think for the therapeutic mammoplasty, and the C cup in the middle, you can use either of the technique depending upon the patient choice and your expertise. So these are the chest wall perforator flap we use. Li cap is lateral intercostal artery perforator flap, L cap is lateral thoracic artery perforator flap, and I cap is anterior intercostal artery perforator flap. So these are the vessels in the lateral part of the chest wall to take out the lateral fold, and the I cap is for the anterior intercostal for the abdominal fold. So this is one of my patients. So this is whole of the upper quadrant tumor. So this was the tumor here. If you can see, this is the left side, the 2-wire post-necessity case. So we planned for a tumor removal with the L-tap. And what we have done, you can see that after removal, this is the defect area. So almost whole of the superior quadrant in a small breast. What we have done lateral thoracic artery plus LICAP, and this is the final outcome. What is therapeutic mammoplasty? Very large and ptotic breast. And if you have large defect, you can displace the tissue and cover the defect. So this technique are multiple way you can do. So marking is very important. I am not going into the detail. So there are multiple steps of the surgery. These are the steps, 6 steps we do: deepithelialization, defining pedicle, covering the defect, and you can give a better breast. So a non-ptotic breast will be converted to a small breast with the tumor removal, and you will give a better breast to the patient if you want. These are some technique we use. This is inferior pedicle. So look the breast in this side. The tumor was on the left side, and this is the final outcome after inferior pedicle therapeutic mammoplasty. This is superomedial pedicle, the same thing, tumor in the Weiss pattern zone. We have used superomedial pedicle, and this is the final outcome after breast conservation surgery. These are some additional techniques: secondary pedicle, split technique, and extended pedicle. So these are the extreme of the oncoplasty. Once you have done 500 to 600 patient of level 1 and level 2, think for using additional procedure using Weiss pattern. And this we are devising now, so dual oncoplasty. So this is the term we are giving, where we are combining two techniques, both therapeutic mammoplasty and chest wall perforator flap, to give a better outcome. So this was a patient here, 6 into 6 centimeter tumor on the left breast. So what we have done inferior pedicle plus lateral thoracic artery perforator flap, and this is the outcome. This I have done 2 weeks before. So oncoplastic versus simple breast conservation surgery, we don't have any randomized control trial evidence, but we have systematic review and meta-analysis of the published data. So as per these data, what I can quote, that there is a learning curve. You need to train yourself. It's not that 1 year of training will give you the expertise of oncoplastic breast surgery. Do your training and try to develop your technique in the next 5 years or 1 decade. Less positive margin because you have the ability to remove more tissue because you can rearrange the tissue. The margin positivity is less with oncoplastic breast surgery, less reoperation. I have seen upon the wound complication rate, it's comparable to the wound simple breast conservation surgery. No delay in adjuvant treatment as per the data, comparable survival, excellent outcome, and you need to discuss the radiotherapy boost with your radiotherapy clip if you are thinking for a level 2 oncoplastic breast surgery. So this is in 2024, if I have to say, I will say that with oncoplastic addition in the breast conservation surgery, it will give you the excellent cosmetic outcome too with the breast conservation. To conclude, I will say that you should have mindset to conserve, discuss with the patient all the options, Whole breast reconstruction, as Dr. DJ Vijay said, that our patients are not ready in general for the whole breast reconstruction. So this is our data of 2023. 943 patients we have operated, 53% breast conservation surgery, 47% mastectomy. Out of mastectomy 440 patients, only 16% opted for reconstruction. Some of the patients were not suitable for reconstruction, but overall, if I am seeing the mastectomy, how many patients opted for reconstruction? It's only 16, so it's 1 out of the 5 patients. And this is the breast conservation data. So level 1 oncoplastic surgery in almost 56% of the patient, and the level 2 oncoplastic breast surgery in around 44% of the patient. Thank you very much. I'm happy to answer any question.
Thank you so much, sir, for finishing it in time, and congratulations for the wonderful work you're doing. Do we have any questions? Yeah.
As a medical oncologist, I'm just wondering, why do patients not opt for reconstruction?
Look, there are multifactorial. First is the cost of the surgery. So once we say that we need to do reconstruction, the simple surgery, even if in the private setup, can be covered in 1 lakh of rupees or 1.5 lakh of rupees. But once you say reconstruction, then it will go to 3 to 4 lakh of rupees. First is the cost. Second thing is that the learning techniques. So how many of us are very good in giving good quality reconstruction? So we need to learn the technique. First, we need to be confident that I can do implant-based reconstruction with less complication. I can do, but I should give less complication or acceptable complication. Third thing is the long surgery. If you are opting for a free flap surgery, it's generally 10 to 12 hours surgery. Long hospital stay, 7-day hospital stay. Simple mastectomy, what the general patient mindset is that simple mastectomy, I will be operated and be discharged tomorrow. And second, the problem is that Indian patients talk a lot with other patients. So they learn from their other experience too. And once they discuss with the next of their kin or next of the patient whom they known to, they will straightforward say that mastectomy is a better option. If you will go for whole breast reconstruction, probably your life will be more complicated, and we need to tackle that question well.
I think I would just like to add one more factor. I work in a government setup and I offer a reconstruction for free. So cost is not a problem, blood is not a problem. The socio-cultural requirement, Indian women, at least the large majority, are still not as bothered about body image. They can very well manage with the kind of dresses we wear. A simple mastectomy bra or external prosthesis is good enough to give them the body image they are looking at. So that is one requirement. Their place in the family is very secure. So their family life is not dependent on a breast. So that is one of the reasons why acceptance is much lower compared to the West, where beach life is part of their life, and nobody can go to the beach without a breast.
Yeah. So, sir, I would like to ask, what is the scenario in your country, sir, Dr. Christian? What percentage of BCS patients they opt for? Yeah.
So
What's
this
the
is-
figure for BCS?
You know, I just have another comment. I really appreciate the way you're approaching this issue. You know, it's not glorifying yourself. It's just a very defined technique to move forward. And I would suggest, and I guess you do this in your team, and the junior learn that they see an individual patient and they give you an idea what the surgical procedure would be. That's number one. Number two, you have to have patient-reported outcomes, because we've seen that so far. Nobody's interested what the doctor is considering, but if the woman has the feeling that it was a right decision, it's number one in your learning curve. I think you should have this year by year, and you can subdegrade it to tumor size, body volume, whatever. But the most important key is the patient satisfied? That's all. And I think I can answer your question after my presentation, if that's fair.
Absolutely, sir.
Okay?
No issue.
Sir, when you are raising a upper, middle, or lower LICAP flap, so sir, routinely how many perforators for a skin flap size of 7 to 8 centimeter? Do you routinely take more than one, or one is enough?
So look, if you are asking for the lateral intercostal
Yes,
artery perforator flap, so lateral intercostal perforator flap, the perforators are present in each intercostal space. So if you are getting 2 perforator in general, better to use 2 perforator rather than 1 perforator. But with the 1 perforator, even if it is a robust, I will suggest that use intraoperative Doppler to confirm. So if there is a good intraoperative sound of the Doppler of that is single perforator also, you can range up to 10 to 15 centimeter too.
Okay. Thank you, sir. That was the.
Thank you so much, sir. So now we would move on to our next presentation by Dr. Christian Jackisch from Germany, and he would be presenting his data on HER2 positive early breast cancer. Thank you so much, sir, for coming all the way from Germany and be here.
So I'll just give a brief background. Dr. Professor Christian Jackisch is the medical director at the SN Mitte Clinic. I'm sorry for pronouncing it wrong.
No.
Professor is a specialist in gynecologic and obstetric department with a focus on surgical, gynecologic, and especially gynecologic oncology surgeries. And he is most recently heading the clinic for gynec and obstetrics at the Sana Clinic, Offenbach. He has been there for 18 years. This is the introduction I was given. Please add to it if you would want to, sir.
Okay, thank you so much for the kind invitation. And wow, the room is loaded. That's very good. And we've heard only questions according to your request from the front rows. So I focus on every one of you. Don't read your emails. You can do this when you're at home. So now it's time that we go back to the title of this meeting, Beyond the Scalpel. And for our chair lady, I guess we take some blood from the screen. For you as a medical oncologist, it would be more convenient not to see that awful surgery, right? And this is why I took the title, What are the New Approaches? And I guess actually it's nice to have all these techniques on board, but this is more or less, this huge movement of tissue is more or less something which belongs a little bit to be provocative in the past. We still have cancer a situation where you need this and you're happy when you have such a skilled training program we just saw. But what you're going to see here is something what we call the neoadjuvant approach on breast cancer and specific HER2 positive disease. I can give you the same lecture for triple negative, but my topic is HER2 positive disease. In principle, it is nothing else than an in vivo sensitivity testing if the systemic therapy with a tumor in the breast is sensitive, yes or no. Or if you just make it much simpler, it's the Pearl Harbor effect. You attack your enemy when the enemy is not expecting the attack. Very simple. That's all you have to know about neoadjuvant systemic treatment. And in biology, you only have the options from A to F. Either the cancer is sensitive, or it's progressing, or it's just melting like butter in the sun, or it's what you're going to see in option C. This is what you have to image. And this is what it makes so complicated, exactly like the surgery we just enjoyed. So these are the definitions for my presentation. I stop the minute the bell rings, or you stop the bell. These are the two options. I think I stop when the bell rings, right? And we've seen this very nicely. Dr. Halstead, actually, he was a surgeon from Berlin, and he was vertical educated. You know, he comes from an army family. He works at Johns Hopkins. And the time I did my postdoc there, I was in his library. It's really breathtaking. And everybody knows this little picture is totally blood-free. And at that time, the hierarchical oncologic understanding is remove everything and then you're going to cure. And that is where we are now. So we have patients who are treated and cured by adjuvant therapy, surgery, systemic therapy, could be endocrine treatment. And others are treated or cured with local therapy at all, elderly women, low-risk cancers of recurrence, for example. And others like triple negatives are, for example, resistant to both. So this is the three options you have these days in breast cancer. So when we talk about primary systemic therapy, we met some good old friends. This is locally advanced breast cancer, and that is, in this old lady, inflammatory breast cancer. Don't ever touch this with a scalpel, because you're doing, you just harm the patients and you will never, ever get to clear margins. So the new consideration is in the mammographies you see down there, this is operable breast cancer because it can perform a mastectomy or breast conservation. We want to downsize this tumor. And as time travels, we got a totally different understanding how to tackle breast cancer. So the local Halstedian approach or the ultra radical Italian mastectomies were vanishing. This is how Dr. Alstead or Sir Dr. Halstead was considering tumor remove lymph nodes, and then you avoid getting metastasis. Wrong. When Bernie Fischer and the Italian guy came up and put the tumor in the center of the considerations and identified those little 4 dots, these are circulating cells. They never saw them, but this was in their brain, and that is giving rise to distant metastasis and local recurrence or bed surgery. So then they identified that the lymph nodes are not the scenario for radical procedures, because these little 4 dots are still circulating. It's a systemic disease from the beginning. Cancer and pregnancy are exactly the same thing. They need neovascularization. The products of conceptions are sitting here, or me or you. But the rest, the tumor you would like to treat. So this is our thinking now. We are not talking about huge cancers. We're talking about what's in the brain of a single tumor cell. And this is due to Charles Peru publication in 2000, that he was identifying different characters of the given cells. Basal-like, luminal A, luminal B, HER2, and now we have thousands of different definitions, but they are not helping us at all. So this is what you're going to do when you do a neoadjuvant primary systemic treatment. Could be chemo plus antibodies plus immuno plus whatever. You first of all have to realize how big is the tumor, multicentric, whatever. You have to prove it and to clip the tumor to see what happens when the patient is coming back in half a year or whatever, 8 months, to know where the tumor was. And then you give the chemotherapy, you take it out, you know this. But the interesting part here is what you're going to see here on the far right. The multi-tissue arrays obviously are different. So you have in this tissue arrays, what we did, you're going to see these are the sequences of different genes which are active the minute you get the cancer diagnosed. Then after your systemic treatment, what you are just inducing is survival of the fittest. So all the cancer cells which are sensitive to your given treatment will vanish, the others will be there, and others who were not very prominent, they grow up because you change the cellularity stress. That's all. So this is what we would like to know. And the bystander effect is that the tumor is shrinking, the axilla is sized down, and we're optimizing the amount of breast conservation surgery. But this is the hot topic these days. And you're going to see the primary tumor is not a clonic tumor. It's not a lymphoma. It's a multi-genetic adventure. You see blue colors, yellows. You can see this by your own. And then if you have a complete remission in the breast or in the axilla, you have no idea what's going on in the circulation. So you can measure circulating DNA, whatever you can manage, but we don't have an idea if this is coming back and giving rise to the metastasis. So what you're doing is you're changing the internal milieu in between the tumor and the host. And that's the beauty in all that stuff. So when it works, it works. You see on the left side, that's a good friend of mine, Cornelia Liedtke, when she's doing her postdoc fellowship in Houston. That was her landmark paper in 2008. And you can see anything what you need out of this graph. If you read it properly, and I just magnified it for you, PCR in non-triple negative breast cancer, it's a flat line. If it works, it works. And then you have the PCR in triple negative, exactly the same thing. Without any immunotherapy. You can add it on, no problem. But if it's not working, it's not working. And I don't need any biomarkers for that. If I have tons of money, I can do it. But for the question that we are asking, I don't need it. And then there was the very first trial we did in Germany, the Techno phase 2 trial, that has published then in 2011 in HER2 positive disease. At that time, it was only trastuzumab. And we showed for the very first time that remission translates in overall survival. And the Americans kind of, these crazy Germans, I don't believe that. Nobody was citing this paper over years, nobody. And this is what we know, that we are just having a snapshot of the chemosensitivity, and that is transferred in complete response or not complete response. And then you're going to see those various subtypes, hormone receptor positive or sensitive, HER2 positive, or endocrine non-sensitive. And you can combine it, and then you're going to see the triple negatives. So this is the simple cartoon, what you can do with a beard tap if you talk to your patient. They need surgery, and in most of the cases, they need any adjuvant treatment, could be endocrine whatsoever. The only thing you're going to do, and I don't need more to explain that to them, is we change the order, and that's all. You get the same surgery, you get the same systemic treatment. No, but we witness how the tumor is reacting. And that is actually the classical sequence. And then you have changing that subject, neoadjuvant treatment, surgery. And now we have something what we call the post-neoadjuvant treatment. Because the golden nugget in that chemosensitivity testing is when you're going to see there's some non-response. And we would like to know what is changed in this tumor. Coming back to the graphs I showed in the beginning to see what is the micromilieu of the tumor that are not responding. It is cellular Darwinism, survival of the fittest. So I just bring this very easy that everybody in the room is understanding that. When you start with surgery, that is your checkpoint number one in your team, based on the individual risk of recurrence. And I don't need a PET CT for this. I just need the core needle biopsy of the breast and maybe the axilla if the lymph nodes are involved, and a good pathologist. And then I make the basement of my judgment of the risk of recurrence. And if the risk of recurrence is low, I put this lady on primary surgery and then adjuvant treatment. And then the checkpoint number 2 is based on all my results. I plan the final adjuvant treatment, including radiation. So these are 2 checkpoints. And in life, you've seen that in surgery, that's exactly the same planning. Very easy, very straightforward. So this is a different scenario. Your checkpoint number 1 calculation is resulting up in a high risk of recurrence equals in systemic therapy. You know this from the core needle biopsy and something else. So that might be the indication for your planned neoadjuvant chemotherapy. Let's put it that way. And to see how effective your treatment was, you're just offering these women surgery. And the pathologist let you know how good your treatment was. And then at checkpoint 2, based on the response data we just discussed, you decide about the next treatment step. This could be adjuvant, post-neoadjuvant, extended adjuvant, whatsoever is created. These are the 2 checkpoints. But the risk travels beyond the scalpel. The primary tumor and the primary nodal status remains. The PCR is a prognostic parameter. Not everyone with a PCR has a long survival. They have relapses due to what I mentioned. And the non-PCRs are those who are candidates for our post-neoadjuvant treatments. So that's a given. So Patty Cortada actually did this first meta-analysis of the available data, and she showed for the FDA that the FDA was approving neoadjuvant treatment as a fast-track procedure for efficacy of drugs, first time ever, because it ended up in overall survival. And here you're going to see, if you stick to the HER2 positive disease, that there are obviously 2 pathways, HER2 blocking and the endocrine route downstream of the receptor. This is why you see different data. If you talk to your patients, number 1 is no patient ever wants to have chemotherapy. But you have to be sure, and the data are suggesting that from the early breast cancer trials group, that there's no misadvantage of keeping the tumor in place for more than 6 months and then do the surgery. This is the biggest fear. Doctor, what's going to do when you nothing do with your tumor? You will wait until you have your first chemotherapy. So this is the evidence from the NOAA trial up to 90%, and the West German cancer trial, the ADAPT trial, 90% is feasible in selected patients. In other words, breast cancer, HER2 positive and triple negative, is a chemotherapy sensitive tumor. So if you go then and try to have the big picture in this HER2 positive disease based on your individualized evidence-based risk of recurrence, and that is linked tumors smaller than 2 centimeters in size and clinically node negative, they go to surgery up front. That is Sarah Tolaney's trial, ATP trial, phase 2, non-randomized, single institution trial, changing the world, you know? So everybody was adapting that without any control trial. And the rest, you know, there's tumors bigger than 2 centimeters in size, nodal positive. Subjects could be to surgery, but usually you put them on a neoadjuvant setting to downsize it and have this judgment what you're going to do. If you have residual disease, then you change your drug like TDM1, and that gains a survival benefit. And that is what Sarah Tolaney was showing us. Reducing anthracyclines, only paclitaxel weekly, and then for 1 year Herceptin, you can give it sub-Q or IV. Both options are valid. And then if your estimation and diagnostic procedure is giving a mismatch, then, and you have a nodal disease, even if you thought it is a node-negative disease, you can add on your trastuzumab, pertuzumab-based treatment in node-positive disease only. Tumor size never matters. And then you can go back to your adjuvant treatment, and that is mostly endocrine, if the tumor is endocrine. If you have a complete response, you have to rely on your core needle biopsy. If you have a non-complete response, you still rely on your core needle biopsy. And then all the other options. And then for patients with HER2 positive disease, you have the extended adjuvant treatment with 1 year of neratinib. So that's the full picture that has been evolved over the last couple of years. But these are the relapses. And we have to be clear that even if we are fascinated by the amount of PCRs, there will be relapses. This is why it is so important to follow up the breast and the patient, going back to the quality of the breast surgery to see what's going on in the affected and in the contralateral breast. I think we've seen that. I just want to mention one point here, neoadjuvant chemotherapy, then surgery, and then the question, pathologic complete response, yes or no. And you all have seen or read the publication, no, the publication is to come now. We just saw the manuscript of the Catherine trial, showing clearly that if you have a non-PCR, don't continue with the treatment and pray that it works. Change to TD1, that was the first ADC in the anti-HER2 world. That is the survival benefit from Sibylle Leubel's presentation at last year's San Antonio breast cancer meeting with a follow-up of 8.4 years. And again, you're going to see in the adjuvant setting here the decrease of the distance metastasis. I would not do much about the CNS metastasis. That's always an issue. Good surgery gives you little local regional recurrences. But I just want to show you another paper, and that is something we just published 2 years ago, and that will be my last trial. So the question we were asking, event-free survival in patients with early breast cancer positive with pathologic complete response in HER2 positive disease. So that were trials that you just saw them with neoadjuvant trastuzumab and then followed by trastuzumab, or dual blockade and then followed by Herceptin, or in green, dual blockade followed by dual blockade. So these are the data, median follow-up, 4 years event-free survival, so the colors are matching. To make the reading easy for you, it's a total of 1,700 patients. The total overall PCR rate was 43.8%. But this is what I want you to take home. If you have a PCR after a dual blockade, do not de-escalate your adjuvant treatment unless you do not have the resources. Because you can see very easily that the distance between the far right corner between the blue and the red line for pH followed by pH is much smaller than if you do something different. And this is a major problem what most of the medical oncologists have, that they try to reduce it. Wow, it's a PCR, but we don't know it, which of the two drugs we're doing that. So I would not de-escalate until I have to do it. And I think in primary systemic therapy, when we gonna see what's happening next, the next generation sequencing of the non-PCR is something what I think is important. Gene expressing profiling will give us a little bit more insight, but even if we have that, we do not have different drugs. And I think we're a couple of years ago from agnostic testing and then treating patients different than with our standards. So this is what I would like to deliver to you, and I'm stop here in the interest of time, and I'm afraid for the bell, but I'm stopping here before the bell ring, and thank you so much for your attention.
That was a wonderful presentation, sir. Any questions?
I think we start in the far right corner. They didn't ask
Yeah,
a question.
absolutely.
Can these people, gentlemen, have a microphone? You don't? Yeah, good. A volunteer. You're assigned for lunch.
So that was a fantastic lecture. So I have doubt pertaining to those patients who has pathological response, but the residual tumor is less than 0.5 centimeters. You give neoadjuvant, you do surgery. At that time, the pathologist says the amount of residual viable tissue is less than 0.5 centimeters. So is there anything where we have to change to TDM1, or we can continue the dual HER2 blockage? So if
So your question is, you do neoadjuvant treatment in HER2 positive disease.
yes,
At the time of surgery, you see the tumor is bigger?
no. If the residual disease, viable residual disease.
Okay, yeah, if you have a single invasive cell in the breast and or the axilla, that's the rationale from the Catherine trial.
Yes.
Then you switch to TDM1 for the rest of 1 year. So the total duration of anti-HER2 treatment is 1 year, and then you count until surgery, and then the rest up to 1 year it's TDM1.
So
If you have it.
even if one viable cell, or if the size is less than 0.5 centimeters, also you shift?
Read the paper, size doesn't matter. We are not on the Onco Bazaar here to trade. It's just, we make a trial with very clear indications. And nobody should actually, with the interest to the patient who are randomized, it's an ethical procedure, massage the data as long as it pleases anyone. So I'm very clear here. It's a huge ethical effort, a randomized trial, which is not controlled by placebo. And then you should take the data, And that is our obligation, to transport this information as clear as is in the paper, to do so.
Thank you.
The mic is not on for those who are just online.
So can I add on that? So suppose giving neoadjuvant chemotherapy to 8 into 8 centimeter tumor, and the residual is 1 mm, and the giving chemotherapy to a 2 into 2 centimeter patient and residual is 1 mm. So do you think that response will be graded as a different in two groups? Because we give lot of neoadjuvant chemotherapy in T4B disease also, T4B N2 disease. Ultimately, what we are seeing that 1 mm residual invasive focus. So do you think that these gradings are not important in T4B disease? And Catherine trial has not represented T4B disease mainly. So it's mainly early breast cancer patient.
So again, I'm going back to my very first comment. This is an in vivo sensitivity testing. And now I'm going to see, with all the limitations of the pathology report, I still have invasive cancer. I change my technique or my drug if I can do it. And we've seen the same thing in a subgroup that has been published in a separate paper. Even if you have in your non-PCR no HER2 expression, it works. Because the treatment is down-regulating that. And then if you have a HER2 negative, for example, some people are doing this. We did it because we were interested in that. don't adapt your treatment at this result. Stick to the primary source. So even, and the question is very fair you were asking, the data are, if you're reading the manuscript properly, you see that just a single cell in the lymph nodes was enough to get qualified for the protocol. Because Roche and Genentech were very keen on that the group of those patients who were randomized were just very clear defined. That's a big issue.
Sorry, can I just add to that as well? Because
Absolutely.
I think,
You can
response,
shoot me dead with your questions.
response rates are a multifactorial process.
As life.
And yes, and it's very difficult to anticipate the reasons why a particular patient responds to a greater degree versus a lesser degree. And if the original trial was not designed to assess that, then like you say, I don't think we should read more into it than that. Secondly, I think how many different subsets are you going to create, and where is the cutoff for the response rates? 20%, 40%, 30%, 80% response in the axillary. So you've got so many variables that you cannot design treatment if you start subdividing.
So where you are heading to is to the residual cancer burden that has been shown in the keynote trial 522. And this is an artificial measure. That's an observation from a pathologist index. And then, grateful to the statistics, Lajos Pustai could show that there's a different response and survival. But we cannot do nothing with that, because if you talk to a patient, okay, you have an RCB of 0, that equals a complete response. Now you have an RCB of 3. I'm so sorry, I cannot do nothing for you. So this is what I think a little bit of academic, and we need this. But at present, we cannot distinguish other than PCR or non-PCR. And one thing is very important. The NSABP was playing around all the years with PCR only in the breast. And the German breast cancer group introduced this total PCR, breast and axilla. And then when the Americans did it, their response rate dropped down. So, I mean, everything is, you have to have the definition. And when you have it, you can make your thoughts. But I have a big ethical problem, and I've been participated in so many clinical trials. The courage of patients around the world to be randomized should be a highly ethical standard for us, not to massage the data. Take the data as they are. For example, I mentioned that, Sarah Talani's trial would never ever meet the standard of evidence-based medicine. It's a non-randomized monocentric trial. And it's standard of care in all the guidelines. That's life. So we don't have a question from you guys there.
I think we'll probably move on, sir, because we can discuss in the panel discussion, I think, in session 2, in the interest of time. Thank you so much. For the next talk, I'd like to
from the delicious lunch that's waiting for you. So
Yeah, so I'll be very quick. I've been asked to speak a little bit about Roche, but I felt the presentation that Dr. Christian Jackisch made, that itself will tell you a lot about Roche, because Roche did help in bringing Dr. Christian Jackisch to this excellent meeting. But I like the fact that throughout his presentation, he's not spoken about anything as far as, specifically pertuzumab or trastuzumab in a fixed dose subcutaneous formulation. He's not spoken about that at all. And that is the essence of what Roche is also all about. So it is a family-owned company, 1896, when the first Olympics happened, so more than 128 years old. But when I first joined Roche, in fact, Andre Hoffman from that family came, and he spoke, his first sentence was, our purpose in life is not to make money, but it is to make lives meaningful. And that's exactly what Roche is all about. So it's all about a lot of emphasis on research, innovation, access. In fact, there is a line which says, where you live should not determine if you live. And then it's all about quality, batch to batch, consistent quality. And that's what, even if you look at the ADC, where that linker is extremely important. And if that linker becomes unstable, you have problems. We've never had that problems with our TDM1. Eventually, I'll just end by saying, if you look at ROCHE, for me, an expansion of that would simply mean research on outcomes, clinical, humanistic, economic. So ultimately, if that is what we do, then that is ultimately going to help patients as well as doctors. And our ethos is to help doctors deliver better outcomes for more patients faster. But it's not just about Roche bringing an innovation to market faster. It's all about patients, if they can get detected earlier, then definitely that potential for cure improves. Because on the one hand, as you know, in drug discovery and development, it would start with metastatic and then adjuvant and then neoadjuvant. But can we get patients to be detected much earlier? And especially in a country like ours, because that is when you're advancing care, and then eventually you have a potential for cure. So that difference between care and cure is just A becoming U, which means you make all the difference. And I was reading this quote from a textbook of surgery, which said, over the years, we have tried to make surgery safer or more safe for the patient. And obviously, it's also time for us to make patients more safe for the surgery. And the same thing applies even to drug discovery and development, that over the years, we've tried to make drugs safer for the patient, but it's also important for us to select the right patient, because ultimately making the patient more safe for that drug. The P value that we know of, the other P is the patient preference. And that I was happy to see that also, where doctors are talking about patient preferences, patient values also as important. So that's all that I want to say. Thank you so much.
Thank you for, yeah.
Ma'am, this was just like a feedback for this session. You can keep scanning it later also, but just wanted to display on the screen. So this is just feedback on the session that Dr. Jakish just gave. So we'd be very happy to receive your feedback on that.
For the next talk, we'd like to invite Dr. K. Sivasubramaniam from Chennai, MDT Management of Early Breast Cancers in their center.
A very good afternoon to you all. No, just a minute. Just hold on. Yeah, it's a slideshow. Can I have control here, please? So, thank you very much for inviting this talk, and for the organizers, and also Roche for introducing me to this meet. I was very surprised that Sir is a surgeon and talking more on medical oncology aspects. It's very, very impressive that he was speaking so much on this neoadjuvant which is basically a medical oncology topic. But being a surgeon, it's very, very impressive that you have contributed so much in the neoadjuvant and the patient benefit. Fair. Yeah, it's working. Yeah, it's working actually. Yeah. Thank you, Dr. Vijay, Dr. Tane, and Dr. Manasi. Why this is termed as early breast cancer? Because most of the time for advanced breast cancer, the sequence is usually the same. We start with chemotherapy followed by surgery and radiation. But for early breast cancer, in our daily practice and especially in India, most of the people end up with upfront surgery. So that is why we are going to have a multidisciplinary team and how we can basically improve the survival and as well as quality of life by giving neoadjuvant chemotherapy. So what does a MDT consist of? So the complexity in management of breast cancer has increased dramatically. For example, we could see the slide how complex it was, how we starting with neoadjuvant chemotherapy even for operable breast diseases, and with the development of precision medicine. For this reason, diagnostic and decision making processes require integrated expertise from all the departments. So a typical MDT consists of an oncoplastic surgeon, medical oncologist, geneticist, radiation oncology, medical oncology, a breast pathology, and also a breast radiologist. So as a medical oncologist, we would like to escalate the treatment, as Sir was mentioning that most of the second line drugs are being brought up in first line. For example, when TDM was introduced, it was a second line setting, and thereby we are bringing it in first line setting for a non-PATCR response. And I would expect that in down the line, probably a fifth line will be coming for a 5 millimeter tumor. That is what is going to be the scenario because all the second line agents are being brought up in first line, thereby increasing the survival. As a medical oncologist, we always want to escalate the treatment, but surgeons, we could see from the previous presentation that they want to de-escalate the treatment, want to be minimally invasive, do a sentinel node sampling, but medical oncologists want to escalate the treatment, thereby providing more survival. So it's always good to have a multidisciplinary team because some of the absolute contraindications might not be known to the other specialty people. For example, a multicentric disease, people might be ending up with breast conservation and thereby having more recurrence. So some absolute contraindications are there. By discussing this in the tumor board, we are able to provide best care. And also we should always involve psychologists because most of the time people end up in depression. I could see a luminal type curable disease. She don't even require chemotherapy. She ended up with depression and she's on pills now. So right from beginning, we have to involve psychologists also in the multidisciplinary team. So these are the recommendations from ESMO. We have to include breast surgeon, medical oncologist, radiation oncologist, a breast radiologist, breast pathologist, and breast nurses. But in India, it's difficult to get this type of particularly focused on breast, but still we can have in a very good corporate setup. And it should always include a psychologist right from beginning, a physiotherapist, geneticist whenever possible. And patients will also have a good positive feeling whenever we are incorporating all the specialties right from beginning. So whenever I call for this tumor board, so some pathologists will tell, don't want to come for this fight club. So it should not be a fight club. It should be a healthy discussion from the surgeon as well as a medical oncologist and radiation oncologist. So this is the requirements for a breast clinic. They should have a proper pathway right from beginning, right from diagnosis, treatment and follow-up. They should have a very good pathway and they should have a MDT meeting. It should be at least 95% of all early and advanced diseases and at least 50% of all metastatic cases should go through this MDT meeting. and access to information should always be available. We have to document both verbally and as well as written information should be available. And there should always be a quality control to check this. We should follow this USOMA quality insurance that should be followed. USOMA guidelines should be followed, and always have a research, training and education. By having a very good data and which is available online, we could have a lot of scientific data from this. So in our setup, we usually have a breast surgeon, a medical oncologist, a radiation oncologist. We have a pathologist, radiologist attending. We do have an intervention radiologist. We do have physician assistant, a surgical oncologist, and IT support persons. So what is lacking for us is we are unable to involve nurses because they should also be involved in this. Geneticists, because we don't do commonly this genetic study. And plastic surgeon, most of them, they are busy. What we do is we do it through Zoom call so that other people also can involve from remote places. Generally, we do at least once a week, but it is better to have 2 or more per week because we should not make the patients to wait for a long time. So whenever we discuss these things, I remember about this WhatsApp joke which usually comes across whenever we talk about surgeon. A radiologist will be telling all the differential diagnoses like BIRATS 2, 3, 4 like that. A pathologist will be telling it should be a fibroadenoma, phylloids like that. And suddenly the surgeon came, why thinking so much? We will just shoot it and take the tumor out and then keep the problem to pathologists, let them decide like that. So surgeons are all heroes. They want to shoot everything at the first sight rather than going for neoadjuvant chemotherapy. But it is very, very important because of the available data that we have to incorporate neoadjuvant chemotherapy whenever possible. So some people in the government setup, they are very clever, even though the rule is we have to go, all the CA patients should go through the MDT meeting, so that PG will be in a very hurry that sir, policy is surgery, sir. Okay, sir, surgery, because he has already made the list of OT tomorrow. So, but just for completion sake, he will be putting up in tumor board. That should not be a routine thing. We have to discuss, get consent from medical oncologists as well. So this is the flow of the MDT. Referral sources, it should have a referral source from primary care physician and imaging centers and other specialists. Inclusion criteria, it should always include all the clinical details before presenting into tumor board, like age, tumor size, as Sarah was mentioning, and receptor status, HER2 status, and also patient preference, which is very, very important. And all the diagnostic images where the radiologist can interpret, and it should be put up in PPT, and the review process should be going through in MDT, and it should be documented through online. And patient-centered care is always acceptable, and communication is important with the patient as well as the other department. And referral outcomes, we have to follow up whatever policy is being taken up in MDT. We should not be deviating from the MDT policy. And quality improvement, we should always try to improve the quality of the meeting and by doing frequently. So these are the typical things where the flow of treatment consists of. So once patient undergoes biopsy, we have to go for a breast surgery consultation, plastic surgery consultation, and many times we come across people without children. They should go for a fertility preservation counseling as well as genetic counseling in our appropriate and discuss at MDT, and they should involve a medical oncology and radiation oncology, and laboratory testing and staging are essential, and get a preliminary investigations. And usually nowadays, for as Sarah was mentioning, any tumor with more than or equal to 2 centimeter as well as node positive, in typically a HER2 enriched as well as a triple negative, we go with the sequence of chemotherapy first because of better pathological response showing a better outcome. And follow-up visits should be documented and informed prior. And after this, we have to refer for surgery, and it is always good to have surgeon visits even every time before chemotherapy, because they will be able to assess the response. Suppose if the tumor is not responding, we can take up for surgery, which is the standard of care. And after surgery, radiation is also involved, and endocrine therapy. So these are the typical cases which made us to think that whether how to improve the tumor board. A 57-year female postmenopausal woman came with case of right breast lump with 3.5 into 3 cross 2 centimeter, and she was ERPR negative and HER2 positive and with suspicious node positive. So always my concern is ERPR negative, we don't have anything to block except for the HER2. So we were discussing about neoadjuvant chemotherapy, but patient was very anxious that she should undergo surgery first. There is no harm in doing surgery first, but as per evidence we are discussing about, so in typical MDT should have a patient preference. At last what happened was she went to some other center because the surgeon offered upfront surgery for her. So this always happens whenever we are giving chemotherapy first, because patient will always have a fear, the tumor is there inside me for 6 months, what will happen to this? You are giving some other medicines, whether it will help me or not. So it is very, it is giving so much problem and mental trauma to the patient to have this tumor till 6 months and then go for surgery. So we should always have patient preference and discuss with them. Another typical patient where we lost her is 35-year female doctor. Again here he ERPR negative and HER2 3+. She opted for mastectomy even though she was suitable for breast conservation, and she underwent adjuvant chemotherapy with trastuzumab mace, and unfortunately she recurred in brain. As Sarah was telling appropriately, this is a in vivo sensitivity. We don't know what happened after the tumor is removed. So probably it was chemo resistant in the first setup itself. That's why she recurred in brain. And this is the effect. There was so much controversy whether MDT was beneficial or not. There are some negative trials also and some positive trial also. This is a meta-analysis of 6 RCT showing a positive trial where it was published in Annals of Medicine and Surgery. It clearly showed that hazard ratio was 0.82, that MDT improved the survival of patients by going through policy of MDT. So whenever meta-analysis is available, we have to make preference for that rather than a single RCT. And other outcomes of this trial are MDT, it worsens outcome whenever it is not followed, irrespective whether it is chemotherapy, radiation or endocrine or targeted. Thus, efforts to promote compliance with MDT guidelines for breast cancer may aid in improving their outcomes. So, MDT does not change the prognosis.
2 minutes.
Okay,
Before we need to finish.
it's about to over. To optimize results, MDT should be well organized. All the information should be available, and we have to give lot of time to discuss rather than rushing. And how the MDT has made impact on life at our center was, it's give time to discuss and interact with the people, other department. Sometimes we may be seeing the pathologist only at the time of retirement. That should not be a scenario. And a plan should be made and discussed with the patient, and intraoperative finding will be shared by the surgeon. Sometimes he may not have missed in the finding in post-op report. He may point out in the during the meeting that intraoperatively we found out this, like margins was close to that, and it's better to have intraoperative finding, as well as pathologist can have added inputs where he cannot comment in the report. And follow-up protocol, we have to have surveillance planning can be obtained from the MDT itself, and survivorship care plan should be told. Lifestyle counseling should always be told to the patient. Psychosocial support right from beginning, because the depression, anxiety and insomnia are very common in cancer patients. Patient education, survivorship clinics should be made separate, and shared decision making should be there always. Thank you very much for giving this opportunity. And this is a very basic topic, but it's very, very important that we should have a MDT, and the things are changing, especially in HER2 enriched as well as this triple negative, where neoadjuvant chemotherapy, even in operable cases, has made a lot of change. This PAT-CR, non-PAT-CR is being changed dramatically. All the second line chemotherapy are being brought up in first line. Probably for even 5 millimeter, we may end up giving up to 5th line of treatment. So thank you very much for giving this opportunity, and I'm happy to have questions.
Yeah. Thank you, Dr. Subramaniam. And if we don't have any questions, sir, Dr. Christian, I would like to just ask one question. What is the scenario of oncoplasty in your country? How eager are the patients to undergo that procedure? I mean, what percentage of patients they opt for oncoplasty?
So we do not have nationwide numbers, but in our guidelines, we wrote down that every patient should be a reconstruction procedure be offered. Since not everyone is treated for the whole duration of the treatment in the same institution, this doctor hopping, I think you know this exactly the same thing. We do not have a nationwide register, but as I mentioned previously to the same question, not everyone is happy. So the procedures we just heard from you, these local oncoplastic surgery, that is something where I would say in the range of 80%. But the more advanced procedures, I would say there's a huge drop. You know, we are just very, very careful with simultaneous reconstruction when it comes to flaps. We first want to have the pathology report because nobody wants to irradiate a flap. So in between, we want to have the report, and then we do this as a two-step procedure, and we are more than happy. I just have one comment to what you said. The only thing which is missing, the MTD should always end up with a written protocol. That's the most, and every second opinion should have a written protocol so that the patient know what was your idea to do it. And you don't have to have a parliament of oncology people. You know, if you have those, and I think your suggestion is very good, genetics, you can have them remote and all that stuff. You don't have to have so many people around. Take the ones who are on place, discuss it with them, and not always the senior is responsible for the best solution. You know, the learning curve is in everyone the same.
Exactly, sir.
Yeah, so thank you, everyone. And if we don't have any more questions, I think we can proceed for lunch. And yeah.
Thank you.
Good afternoon, everyone. So after this wonderful session, we now break for lunch. We thank our chairpersons. We thank all our four speakers. And lunch is arranged on this very same floor at Jarwani restaurant. And there is a small reminder for all of you that we have arranged a visit to the beautiful monument Statue of Unity in the evening time. So as soon as the academic session is over, we request all of you to gather in the reception area. We have made special arrangements, and there is a wonderful laser show to witness over there. So I just invite you, all of you, for lunch. And because of paucity of time, we have curtailed the lunch time to 30 minutes. So we reassemble by 2:15 p.m. Thank you.
Basil Oncocare Hospital at Surat. Thank you very much. And next chairperson, Dr. Maitri Gandhi. She is a radiation oncologist at HCG Cancer Center, Ahmedabad. Thank you.
Hello friends, hope you enjoyed a good lunch at Keodia Colony. It is one of the dream of our Prime Minister Narendra Modi and we are situated at his heart. So I would like to invite post-lunch session Dr. Mansi Shah to share their experience, tertiary care center experiencing neoadjuvant HER2 positive early breast cancer. Dr. Mansi Shah.
Thank you so much. So I'm going to be presenting this data, which is from our own institute. I'm presenting this data on behalf of the entire breast oncology team. This is led by Dr. D.G. Vijay and Dr. Tanay Shah from the surgical oncology department, Dr. Kinjal Jani from the radiation oncology department, and I'm Dr. Mansi Shah from the medical oncology department. So we do have a lot of experience of dual HER2 blockade in the neoadjuvant setting from the West. However, when you look at Indian data, there's always paucity of Indian data. There's one study which is published by Dr. S.V.S. Theo, and this is, I think, to the best of my knowledge, the second experience that I'm going to be talking about today. I can skip the epidemiology of breast cancer in India. I think it has been touched upon. However, just of note, we know as treating physicians in India that our patients definitely differ from those in the West. We do see a lot of younger females. We do see a lot of advanced cancers. We are not as fortunate as the West to be giving neoadjuvant treatment to node-negative patients a lot. And hence, I think it's important to look at what our outcomes are. So this is a multi-institutional real-world data study from India. If we look at non-metastatic breast cancer patients, how do they turn up to our centers? 66% with stage 2 disease, 21% with stage 3 disease, 20% of HER2 positive cancers, 25% of triple negatives, and about 55% of hormone positive patients. This has been touched upon in the previous studies, so I'm not going to go into great detail, but we are looking at pathologic complete response in the neoadjuvant setting because it has shown to improve long-term outcomes. This is something that Professor Christian Jackish has already touched about, that dual anti-HER2 blockade is better than single in terms of event-free survival, even in those patients who have a complete pathological response. And based on all the literature that we have so far, all the main clinical practice guidelines, including the SOU NCCN, they do recommend giving neoadjuvant treatment to clinically T2 or greater disease or node-positive disease, and then escalating in the adjuvant setting depending on the pathological response. So this is our own institute experience. This is data collated over patients who have received dual anti-HER2 blockade over a period of 2 years. So we've were able to collect data of about 53 patients. Median age at presentation was 51 years. We did see almost about 22 patients who were less than 50 years of age, and majority of the patients had hormone positive disease, so 55% versus 45%, so triple positive disease in 55% of patients. If you look at the tumor size, T2 was the most common tumor size for which we have given neoadjuvant therapy, and N1 node positivity was the most common nodal involvement status. Most of these patients received a non-anthracycline containing regimen along with HP. So I think this is a trend that we as medical oncologists are moving towards to avoid anthracyclines because of concerns for late toxicities, and probably because, also of the fact that we're not seeing any increased benefit of giving anthracycline in this subset of patients, especially if you're using the optimal anti-HER2 therapy. So only 7.5% patients received an anthracycline-containing regimen. 70% received docetaxel, carboplatin, trastuzumab, pertuzumab. And then there were some other patients who had received other regimens either without carboplatin or weekly paclitaxel based upon their comorbidities. So if you look at the total pathological complete response in all of these patients, it was about 51%. In patients who received TCHP, all 6 cycles, the PCR was 58%, which is pretty much in sync to what the Western data is showing us. Of the 15 patients that did not receive TCHP, so either they had received an anthracycline-based regimen or some other regimen, 7 patients achieved a PCR, so about 46%. Like I said, these regimens included either weekly paclitaxel with trastuzumab, pertuzumab, or an anthracycline regimen. If we stratify the response rate as per the hormone receptor status, as expected, hormone-negative patients had a higher pathological complete response, 65%, compared to hormone-positive patients with a pathological complete response of 35%. If you look at the surgeries, 46% patients underwent breast conservation surgery. Going back and looking at the data, we found that if patients had undergone upfront surgery, then based on their characteristics, tumor characteristics, the number of patients requiring mastectomy would have been around 69%. So we can say that the conversion rate from mastectomy to a breast conservation surgery because of neoadjuvant therapy was 22%. Of concern, this is what we had talked about earlier, patients being concerned or clinicians being concerned about the fact that we are not doing surgery, tumor can progress. 100% patients that underwent neoadjuvant therapy underwent surgery. There was no evidence of local progression that was noted prior to surgery. Looking at toxicity of just the anti-HER2 agents, there were 3 patients that developed grade 3 diarrhea that required hospitalization. No added cardiotoxicity was seen in any of these patients, so none of these patients had an asymptomatic or symptomatic drop in the ejection fraction. So just to conclude, ours is a tertiary care center with a dedicated breast unit, and the median age for our patients with HER2 positive disease was around 50 years. Higher percentage of patients with hormone positive, HER2 positive disease. Clinically, T2 and 1 stage accounted for 67% of patients that received neoadjuvant therapy. A non-anthracycline-based regimen, TCHP, was the most commonly used regimen with a pathological complete response rate of 58%. HR negative status conferred a higher pathological complete response as expected. We were able to provide a breast conservation surgery instead of mastectomy by giving neoadjuvant therapy in approximately 22% of patients. There were no added toxicities or loss to surgery because of giving neoadjuvant therapy. Grade 3 diarrhea was the only significant toxicity that was seen. And, I think I did not have the genetic data on all of these patients. We had data on only 6 patients. They were all negative. But I think, especially for younger patients or patients with a significant family history, I think giving neoadjuvant therapy, in addition to offering them time to kind of digest the disease, genetic counseling, decisions regarding surgery, psychological acceptance of the disease. I think these are all other important points that, we do not have objective data on, which I think it has really helped. So if anybody wants to add, Dr. D.G. Vijay or Dr. Tanay, Dr. Kinjal Jani to, whatever is there, I think we need to collate more data to see how we are doing. As of right now, from whatever we are seeing, I think we are having the same response rates as what we've seen in the clinical studies. Thank you.
Will we conclude or any questions from the audience? Yes.
Hello. There is a pathologically complete response in 51% or 58%. So is there any different data, like what is the complete response rate in the nodal region and what is the complete response rate in the primary area? Like which is more giving response?
So actually, can you open my presentation again, because I had a detailed slide about what kind of response each individual patient had. So to answer your question,
but axillary response rates were high. Yes.
so there were responses in the axilla as well. However, breast responses were much higher. Of course, because we are doing radiological staging, there were certain patients with N1 disease who at the time of surgery were actually upstaged in their nodal status. We don't really know. But pretty much all patients did have a response in the node, less or more. But breast responses were definitely better. If you look at patients with T4 disease, T3 disease, they really had a significant response in the breasts. Nodes as well.
No. So generally, nodal response generally comes better by and large in the neoadjuvant setting, and it can help in giving benefit of SLNB in this patient. And second question is, what is the adjuvant therapy provided to these 58 patients, 53 patients?
So all these patients who had residual disease were counseled for TDM1. How many of them actually took TDM1 probably would be an important point to note. It was not 100% for a variety of reasons that we already know. So they were all offered TDM1 if they had residual disease. There were some patients, because of the patient assistance program, since they were already on H&P, dual agent, they continued on H&P. And then there were some patients who actually went on to receive TDM1. So majority of the patients had either HP or TDM1. I'm sorry, so counsel for TDM1, but then it depended on their financial situation. There were actually 2 patients who were switched to TDM1. They went back to HP because of toxicity. One had severe residual peripheral neuropathy and couldn't tolerate TDM1. And the other patient had significant thrombocytopenia, and the TDM1 dosing wasn't adequate, so it had gone back to HP.
And those for PCR also continue with the HP or single agent after in adjuvant setting?
So I think it was 50-50. We do counsel our patients for continuing HP if they've received HP in the neoadjuvant setting, considering that, we consider them as high risk, and we don't know which agent is more important, or, the pathological response is probably because of the combination, and maybe the single agent wouldn't have done it for them. So we do counsel patients to continue if their finances help them.
Sorry, I just wanted to make a comment. These staging and the comment that you made on upstaging, I don't think I'd be much worried about it, because the pre-op staging methodology is completely different to the post-op. So pre-op, you may not be able to pick up everything.
Yes.
I'm sure they had PET also, right? Pre-op.
And regarding TDM1 toxicity, please look up on your data, because as per our data, discontinuation of TDM1 is in almost 30% of the patient. So probably we are seeing higher toxicity than what was reported in the trial and discontinuation of the drug in real world setting in India.
In the adjuvant setting or in the metastatic
So in the
setting?
neoadjuvant setting, when if it is incomplete response, you have changed to TDM1. So there is a lot of toxicity and lot of discontinuation as per our experience with the TDM1.
So I've also noticed that in the adjuvant setting, patients try and want to opt for less toxic regimens. It is also a psychological thing because they've already undergone toxicities for chemotherapy, so they're less driven to take toxicity for 1 year when they are cured. So discontinuation rates other than toxicities are also there because of other reasons. But definitely I agree, TDM1 is not as well tolerated as trastuzumab or the trastuzumab-pertuzumab combination.
Let me ask you a quick question. I highly appreciate the internal quality control, what you are showing us in your own patients. How did you find out the nodal involvement? Was this clinical assessment only, or are every patient where you have a N plus or N1 assessed by corneal biopsy from this lymph node?
So only in suspicious lymph node involvement, we are doing a core biopsy. For patients who have clinically node positive or radiologically node positive, we are not doing core biopsies as routine.
Thank you for the wonderful talk and a great insight on our experience at HCG Cancer Center. Now I would like to invite the moderator of the next panel, Dr. Gaurav Agrawal. There is a panel discussion on response assessment and tailoring local regional therapy approaches in new adjuvant setting.
Before Gaurav comes on stage to answer your question, Sanjit, could it happen that the generic TDM1 has probably more side effects than the original research, because you are comparing the generic TDM1 with the original research molecule Kadcyla, because all our patients receive only we have a very fine generic TDM1, and we are using that in the post adjuvant setting. Not many of our patients actually go on to receive the original research molecule. Okay.
At present, we don't have any Ujvira data in adjuvant setting. But we still use.
Okay. Good afternoon, everyone. And firstly, thank you, Dr. Vijay and Rosh, for inviting me to this meeting, to this unique location. And I look forward to seeing the more important, absolutely. Not just today, but even in future. So we have heard a lot about neoadjuvant systemic treatment in early breast cancer patients and how it has been benefiting our patients and us. But then while these patients are on neoadjuvant systemic treatment, we need to gauge their response to the treatment. So we have an eminent panel for us to help decipher some of these questions. Can I request Dr. Niket Shah, surgical oncologist, Dr. Abhishek Jain, surgical oncologist, Dr. Ketul Puj, surgical oncologist. Oh, can someone? Dr. Kinjal Jani, radiation oncologist, Dr. Christian Yakesh, surgical oncologist, Dr. Santosh Chelapuram, a medical oncologist, and Dr. Nandita Shashikaran, a radiation oncologist. Welcome all. And so,
Can you see the screen?
the panel is heavily favoring surgical oncology, which is a welcome change for me. Otherwise, in majority of oncology conferences today, the medical oncologists walk away with the cake, and then we are left with some crumbs. Thank you for choosing such a panel for me. How many of you are, I mean, do you agree with this statement? Contemporary breast cancer surgery, it's all about doing, achieving more with less. I see quite a few hands going up. Majority of the gray-haired, experienced people have put up their hands. Why are the youngsters lagging behind? Why are you so unsure? Or is it that you're still not sure what less means, or how can less be more? Let me try and prove that to some extent for you. So we have heard today that neoadjuvant systemic treatment is the standard, or rather we have not heard about this part. We have all known for ages now that for locally advanced cancers, for large operable cancers, neoadjuvant systemic treatment is the standard of care. It facilitates operability. And in all these patient groups that are projected in front of you. But the focus today is how is neoadjuvant systemic treatment helping us treat our early breast cancer patients better. So that is what we're going to discuss today. So for the sake of, I mean, again, these are issues which I can take for granted. All of us are well aware that in early stage cancers, when we are dealing with a triple negative, HER2 enriched, or selected large luminal B cancers, we often employ neoadjuvant chemotherapy. Let me start with the panel here, and Dr. Chela, Dr. Santosh, can you please throw more light on, is that statement correct? Is this appropriate to offer neoadjuvant chemotherapy or neoadjuvant systemic treatment of this group of patients?
As we have discussed in the previous panelist also, our esteemed lecture we have heard. So what I would do is, am I audible?
Yeah.
Yes. So in this scenario, in a HER2 positive or triple negative, I would give neoadjuvant whoever is node positive, and if it's node negative, I would use if it's more than T2. So these are the criteria that I follow in my day-to-day practice. Any node positive or more than T2. So this is the neoadjuvant strategy I follow.
So any contrary ideas from the panel? How many of us offer neoadjuvant to T1C patients as well? Of course, node positive we would. No one? Okay, so all of us agree that we need to select patients appropriately, those who we think will benefit significantly. And neoadjuvant systemic treatment in this scenario helps us de-escalate treatment by facilitating breast conservation, by employing sentinel lymph node biopsy rather than accelerated dissection. It also provides us with the vital prognostic information, and we have heard in the previous two talks how pathological complete response has a definite bearing, and we can select patients for post neoadjuvant treatment by documenting residual cancer burden. We can select patients for adjuvant or post neoadjuvant chemo treatment in patients who are triple negative. We can offer them capecitabine and TDM1 or other appropriate treatments in HER2 enriched. So these are the two group of patients that I think the panel agrees deserve neoadjuvant chemotherapy when we are talking strictly of early breast cancer. N2 and worse are not early breast cancer, those are locally advanced. T4 are certainly not early breast cancers. And primarily, this group of patients, we are bothered about de-escalating surgery. Is that correct? Is this something we can all agree to? Or
I would just rule out the CN1 because you have to have proof that the lymph node is involved. So CN1 is, it is yin-yang, 50% yes or no. So I would
Okay.
be very cautious to accept that, but if you do not have the chance or the patient is refusing the usual exusions, then you have to work on that. The one who will ask you this all the time is the radiation oncologist. It is just an enlarged lymph node or it's a positive lymph node. That's the only question.
Yeah, so I think that's a very pertinent issue. How many of us routinely undertake a guided FNA from an enlarged or a suspicious node? I see number of hands going up and in the audience too. So as and when, unless there is any specific reason why you would not, you would like to document the status of the lymph node based on at least cytology. Of course, as we would discuss later in the next debate, how do we address or how better we can document this by doing core biopsies and perhaps flipping the nodes. So the idea about treating early breast cancer patients with neoadjuvant chemotherapy or systemic treatment is to de-escalate, to reduce the tumor volume, the breast tissue volume that you excise at conservation, achieving more conservation, achieving more meaningful conservation by reducing volume that you are excising. We heard this morning from Dr. Sanjeev how we can do better oncoplastic procedures if you have to excise lesser tissue volume. Every centimeter diameter that we can de-escalate allows you to reduce the excision volume by 3 to 4 folds. There are a number of studies. This study that I have put up right now actually was meant for a very different reason, which shows that by reducing the width of margins that we excise by 1 centimeter, we are reducing the breast volume excised by this much. Conversely, by reducing the tumor diameter by this much, by 1 centimeter, again, you'll be able to achieve this much reduction in breast volume. Okay, so does choice of the neoadjuvant systemic treatment make a difference? I think it's a no-brainer. Everybody's from this morning's discussion is very well versed with that. Yes, appropriate type of chemotherapy, anti-HER2 treatment, single or dual, and perhaps immunotherapy would make a difference. And if PCR or achieving PCR is a goal, we would achieve this goal to a different extent if we were not to use. But let me specifically ask one rather controversial question. Today, we are talking of dual anti-HER2 targeting. And yes, trastuzumab plus pertuzumab combination is the way to go. But how often and SCG have an excellent set of data that almost all your patients who required neoadjuvant anti-HER2 treatment could be treated with dual anti-HER2 blockade. But you treat perhaps the elite of the country. What about the real world in rest of the country? What proportion of our patients are able to afford dual anti-HER2 treatment? Can we start from here, my friend? What proportion of your patients are actually receiving?
So I guess it's somewhere around 15 to 20% of our patients who turn up for pertuzumab. The treatment becomes very expensive, and that's only that leaves the patient
Okay,
only with
15 to
trastuzumab.
20%.
Yeah.
Okay.
Same, I think it's very dismally low, 10 to 15%, that's it.
I work with Dr. DG Vijay.
Okay, so sorry. You do not.
Less than 1% at GCR, right? Government Institute.
Okay.
I'm from a private hospital as well, and I would say about 50 to 60%, almost similar to what Dr. Mansi presented.
So it's varying widely. Why would the patients being treated in government hospitals, where I feel majority are now being supported by one government support system or the other, PMJAY or other state-driven insurance schemes, yet the uptake of pertuzumab is so dismally low? The answer is that, for example, Ayushman Bharat does not support pertuzumab. So, and this is in our own experience at LGPGI, in recent years, close to 40 to 50% patients have been affording it. but they are supported by other kind of insurance schemes, mostly, and very few out of pocket. This is one fact of life for us. So does that mean that patients who are HER2 enriched, and if they cannot afford dual anti-HER2 blockade, they should not be offered any anti-HER2 treatment, Dr. Yakis? Dr. Krishnan Jakis, would you perhaps address this issue to some extent?
No, I mean, we are just playing this ball back and forth. You know, you can only treat what you have. And if you don't have this dual blockade, then trastuzumab is better than nothing. So what you should not, or what people should not do, is just use pertuzumab. I've seen this in some places. It doesn't make any sense. But I have a comment to a previous slide of yours. The reference was 2007 on that slide, and it took a couple of years until the surgical society or community understood that the margins traveled not with the subtype. So there were a lot of guidelines that were asking for a bigger free margin in triple negatives than in other tumor types. And due to Monica Morris' approach, so we're talking about clear margins that is not a single cell. Sorry, but I don't think that 1 centimeter is a measure at all that we should use. I mean, we are jeopardizing more or less the rate of re-excisions, but I would rather go for that than to have a 1 centimeter clear margin to all sides, which is again affecting the amount of reconstruction.
Point well taken. So, but going back to this issue of neoadjuvant anti-HER2 treatment, the point I'm trying to make, and has been supported very well by both Dr. Jakis' talk and his comment now, that patients who cannot afford dual anti-HER2, it's better to give them at least trastuzumab. Now coming to assessment of response to neoadjuvant chemotherapy.
Sir, one answer pertaining to the previous. Those who would not afford for pertuzumab, we would try to push always anthracycline in them, sir. So rather than non-anthracycline, give always an anthracycline, where in HER2 it has much more action compared with that one. So that is one thing we compulsory do.
And would that also be dictated by their hormone receptor status? Would you, irrespective of hormone receptor status? Okay, fine. So you have decided, your MDT has decided the patient to be treated with neoadjuvant systemic treatment, but the surgical team or whichever team is following this patient, how do you assess if the patient is responding well? What's your way of monitoring response or assessing response to neoadjuvant systemic treatment?
We tell the patient to visit at least after every 2 cycle. Ideally, after every cycle it should be followed up, but after every 2 cycle, just follow up with us, and we do a clinical examination. And if it is response is better, then we can continue the chemotherapy. We don't do any objective tests if there is a response.
Okay, so the initial post 2 cycles, clinical examination is sufficient, but when would you do any further imaging or repeat imaging? Maybe you can...
Sir, if it's a node positive at the beginning, or if it is a clinically T3, T4, I think I would like to get a PET scan done again after all the NACT has been finished. And MRI, we don't resort to very often. So most of the time it is clinical examination followed by mammosono or PET scan.
Okay,
Yeah.
so certainly not after every 2 cycles or at every assessment you would like to do imaging, but when?
Can I add a comment?
Please.
So at times we don't, when we are pursuing BCS in a patient, we don't put the clip at the first go. We call the patient after 3 or 4 cycles of chemotherapy. We assess the response, and that is when we place a clip inside the tumor.
That's a very pertinent point. So in patients who are responding well, and especially triple negative, where you are afraid of the tumor melting away, or in patients who are luminal cancers and you have to use for some reason neoadjuvant systemic treatment, you want to ensure that there's a concentric, the pattern of response is concentric and not Swiss cheese. You would like to put the clip after at least 2 cycles of, at the time, you may have to repeat your imaging. But MRI has a certain role in specific cases. Would somebody like to address that? Dr. Jackish, when would you like to use?
We'll make it very simple. If I have a centric lesion and it's traceable with ultrasound, that's it. Of course, we have a bilateral mammography, 2 views. If that's a clear picture, we don't do nothing. If it's a dense breast, we might add an MRI. We never ever did a PET CT scan to do this, but we clip the minute we start the neoadjuvant treatment. But this is just to our personal protocol, you know, that you're not forgetting that. And during the course, the only reason for imaging is that you would like to be sure that there's no progression. And we do the imaging usually after whatever 4 cycles of treatment. We see, like you mentioned, these patients at every cycle for just how they're standing the treatment and the side effects. And it's a short and brief interview. And then we document the imaging after 4 cycles. And then, of course, prior to the surgery, and then we have a 2-view mammography of the clip, because we always know sometimes these clips are walking around in the breast, you know, and when you have a complete response, you want to make sure that this is exactly the same position of the clip like prior to your systemic treatment. So that's all.
Thank you. So I put up these 2 metabolic or PET scan and pathologic assessments. These are, I mean, PET scans are not indicated in early breast cancer patients, and we do not and we should not promote their use. And pathological assessment is only to be done at the time of surgery, but with some exceptional cases where you may like to. How can, in terms of assessment of response, what bearing does it have on the eventual planning for radiation, Dr. Sasuke?
So I don't think, again, the response assessment part will be the ultimate sort of factor that you would take into decision making. It is your pathology report at the end of the day. So the only thing which has changed in the recent times is the de-escalation of radiotherapy in these sort of N1 patients who respond really well to neoadjuvant treatment. You have the NSABP B51, which came out as an abstract in SABCS. So normally any node positive who's undergone a mastectomy, you would subject them to radiotherapy even if they had a PAT-CR. But this study says there is no added locoregional benefit or even distant recurrence benefit. So I would take that call based on the pathology report, not so much on the response assessment part.
So pathological assessment alone.
Yes.
So that too is a way of assessment. How can we have better assessment? What can help? Would marking of the tumor be considered an essential part of management of these patients? Or, as I am aware, some centers, some surgeons do not consider that. What's the opinion of the house? Marking of the tumor either before initiation of neoadjuvant systemic treatment or during or after some cycles. Is it helpful? Well, the answer obviously is yes, but can we do away with this at least in some subset of patients?
If there are mammographic calcification at the tumor site, when we have done the initial imaging, in that scenario, no marker is required for gauzing the site of the tumor, because they tend to persist. Even though there is tumor shrinkage, this calcification will persist. It is actually a marker that is already inbuilt in the tumor. In that scenario, no additional markers. Timing of when to put the marker depends on the size of the tumor. So if it's a large tumor, maybe after 2 to 3 cycles, when the size comes down, we put. If there is small tumor, we put upfront in both breast and axilla at the time of start of neoadjuvant, assess clinically after every cycle.
Great. So now it's all about de-escalating surgery, that we are practicing neoadjuvant systemic treatment. And there's been some concern about higher recurrence rates in patients who undergo post-neoadjuvant systemic treatment breast conservation. What's the view of the house? Is that correct? Do we need to counsel our patients differently, patients who are undergoing primary breast conservation versus those who are undergoing post-NSCT breast conservation? Dr. Rakesh, you think
The standard of recurrence is the recurrence after mastectomy. So that's in all guidelines, it's a standard, and this is about whatever 2 to 3% every 5 years. So that's your margin. Then, like we heard this nicely about the HER2 positive disease, you should have your own quality concern, and I wouldn't see any difference here. I mean, locally advanced breast cancer is, for me, to be very honest, a very rare indication for breast conservation. Because, you see this, I mean, if you just, for a minute, a lymph vessel, I'm not talking about inflammatory disease, but, this is not like melting in the sun. It's a discontinuation. And even the best pathologists cannot find it. So I would not jeopardizing the rate of local recurrence in locally advanced breast cancer. So I would have a clear-cut lesion, a solution here, have clear margins, and then put the patient on radiation. That's the only option for optimized locally controlled. And then maybe after 1 or 2 years, I would consider that, but that would not be my very first choice. So
Also-
this is the same thing in, you read it in some guidelines, if the redness in inflammatory breast cancer is only 2 centimeters, then you can do it. I just regard this as not valid. I would not do this. Sorry.
So clinically, T4B is a strict no for a breast conservation surgery. But if it is a LABC because of N2, then still I think we can go ahead.
I'm sorry.
Yeah. So
Comparing post-anesthetic mastectomy with post-anesthetic BCS.
Oh, yes, there is, but unfortunately, these are all mostly retrospective data. No prospective trials are there. I'm sorry, this is a mistake here. The point of discussion should restrict to early breast cancer because LABC is an entirely different ball game. Facilitating safe breast conservation is I mean, there are various things you can do, marking the tumor wherever it is important, but then assessment of margins, though it cannot be overemphasized. Even with primary breast conservation, this is a critical step in breast conservation surgery, but even more so in patients who are undergoing breast conservation following neoadjuvant systemic treatment. And I'll be skipping the sentinel lymph node part because that can perhaps be taken up in the next debate. So it does make difference marking of the tumor before or during neoadjuvant chemotherapy. And I'm sure all of you are aware of this important paper from MD Anderson's Cancer Center, Julia O. She very well documented patients who had a clip placed had better control compared to those who did not have a clip placed before neoadjuvant chemotherapy. So now, again, this is a question which doesn't require an answer. Not all cancers respond equally or similarly. And again, another question which is so obvious today, that the response depends on the biological subtypes. So based on these two facts that we all know, do we counsel or do we explain the anticipated outcomes to our patients differently? Is that a practice, or do we not do that as far as anyone, maybe Dr. Jain or?
So with HER2 positive and triple negative, we know that the chances of recurrence are highest in the first 5 years. With hormone positive, they usually recur. If they recur, it's usually late. So we always tend to explain them that the first 5 years are going to be very important for you. And yes, definitely now, since the treatment is totally based on the biology, I mean, it has now changed entirely after ER/PR and HER2. So it does make sense to tell the patients that the biology is different, and so the outcomes will also be different.
Well, that's I mean, that's an appropriate statement to make, but then that is concerning all patients,
right.
Specific to post neoadjuvant
local regional surgery you're talking. Yes, sir, as far as the local treatment for the breast primary is concerned, so for HER2 positive, we always expect a good response from the tumor. So we always counsel that if the tumor decreases drastically, there's always a chance of you getting a breast conservation surgery. So yes, TNBC and HER2 positives We still hope for a good response, always.
Sir, the main rationale of giving neoadjuvant is to identify this bad subset, those who do not respond, so that we can update or adapt our treatment subsequently, as adding of Catzilla or adding capecitabine in case of TNBC, identify these bad subsets who did not respond adequately, so that we can modify or adapt our systemic therapies.
I think that this is a great statement. Thank you for that. You exemplified the difference in approach of surgeons versus medical oncologists. We want to identify the good subset first and then identify as a result, as a byproduct, the bad subset, because we want to identify to de-escalate treatment of good subset and of course choose out prolonged treatment for those who do not respond as well.
So this is a little bit too oncodiplomatic for me. You know, I think the cancer cell cannot read what's on your coat if you're a surgeon or a medical oncologist. If you have the time, I would recommend that you read Sarah Tolani's latest publication. It was, I guess, Lancet Oncology, with her 15 years follow-up on the ATP trial. So she was doing PAM50 tests in her own institution. I guess it's a high volume pathology institute. And given the fact that that she was considering that all these tumors were HER2 positive, there was a huge variety on that one figure, showing that there are totally different subtypes, or a lot of different subtypes, what we assumedly name HER2 positivity. So in an ideal world, when, you know, I would use one of these multi-gene tests, and preferable PAM50, to see what the real signature within a subtype is. The same thing is with triple negative and the luminals and all that stuff. And I guess that we then identify those who will not respond because they are intercellular, not HER2 positive, you know? What people are mismatching, that they kind of asking, okay, then there are HER2 low. But this doesn't belong to early breast cancer at the moment. So people are mixing up, mostly those people who do not read the papers. They have a totally dissonance in their brain, mixing up figures and fairy tales. So I would be very, very cautious. You know, the subtype, as far as we know, they do not respond the same. And what we do not know is the extent of the intracellular matrix. So what the host is giving to the tumor environment. So this is so complicated, or it's so different. But for the time being, I think I'm coming back to my very first slide this morning. It's an in vivo sensitivity testing, and that's it. And we have to live with these results. You know, we cannot massage the data. I would love to have it that way. And it doesn't make any role if there is a response in the breast and not in the axilla, or in the axilla and not in the breast. It's the same thing at the moment we are speaking.
Okay, so our time is coming close to end. Yeah. So these two final issues that we can discuss very quickly. Is RECIST good enough while assessing response to neoadjuvant systemic treatment? From the viewpoint of planning the local and regional treatment, we know the magnitude of response, 50% more or whatever, for progressive versus stable disease versus partial response and complete response. But when it comes to planning of the surgery, we need to know the absolute size reduction, absolute size post reduction, and the absolute status of the nodes, rather than just RECIST. And the pattern of response to neoadjuvant systemic treatment is not universal, not uniform. It can be concentric, like it is in majority of triple negatives, or it can be Swiss cheese that we see typically in patients who have luminal cancers. But more often than not, it is a combination of the two. There's a concentric as well as Swiss cheese kind of response, the kind that you see in this cartoon. So I think our time is up. If there's any pressing comment any of the panelists would like to make, you're most welcome to do that now.
Anyone? Any clinical trials that you have done, have you ever used Ki-67 as a marker of response to neoadjuvant?
So this is a very good question. The answer is no. We've never done this. We are doing this in endocrine responsive. So Ki-67 is a marker, you can't shoot it down. You know, we were considering that it was gone, but now what we are doing, and it's not our topic, but I would love to answer your question, in luminal B and A cancers, node negative. Our standard of care, due to the evidence from a large running national trial, that's the WSG umbrella tie, it's called the ADAPT cycle, that has been displayed in ASCO and San Antonio every year, the data. So if you have a luminal A or B cancer with a Ki-67 of more than 10 to 15%, we offer those patients for maybe 3 to 4 weeks. If they are premenopausal, aromatase inhibition plus ovarian downregulation, and postmenopausal woman, aromatase inhibition. And then the tricky thing is you have to have the measurement of Ki-67 in the same lab from the core needle biopsy and then from your surgical specimen. At the moment, we are combining this with the oncotype, which is exactly from the very same core needle biopsy. And now you can realize that you have an in very short period in vivo testing of the endocrine responsiveness. When the Ki-67 is dropping, you know your endocrine therapy is working. So we have just submitted, or it's accepted in breast cancer research and treatment, a series of real-world data, 600 patients, where we would like to show that Ki-67 is not fencing, for example, from 10 to 40% the decision for for an oncotype DX multigene assay. The tumor biology, what you can discover with the multigene test, oncotype or MammaPrint, whatever, you can name it, is so precise that it is overruling the testing quality of Ki-67. But if you don't have the chance to use it, then Ki-67 in a very good lab, and we did it in a blinded fashion, it is very, very helpful. So you can convince yourself that the endocrine downregulation with your standard treatment is obviously working. It's a fantastic, simple, and cheap technique. Could be done in the Tata Memorial, you know. It's very genius idea. The next question then would be, if the Ki-67 is not going down, are you then offering adjuvant endocrine treatment? But we have no idea on that issue, you know. That would be your next question. But we're going to see this, whatever, in 5 to 10 years. So what I'm saying with that is that you can, even in the luminal cancers, reduce the amount of, you mentioned that in your first step, unnecessary toxicity due to chemotherapy, because it's not working. So the endocrine route of regulation is totally different. What we are doing was knocking down the enemy with our chemotherapy. It still remains totally fascinating, and the more you know, the less you know. So it's different than in surgery.
So I thank all the panelists and the audience. Thank you very much.
Thank you, Dr. Agrawal and whole panel to enlighten us how we can achieve by doing a less and more results. So, continuing with the same philosophy, I would like to invite Dr. Christine to moderate a debate for sentinel lymph node biopsy post neoadjuvant systemic therapy. So, Dr. Christine will enlighten us with this topic. Then our speaker for is Dr. Rajiv Bhatt, and for the against Dr. Sanjit Kumar Agarwal.
Okay. So this was your decision to call up this session, right?
No, it is Dr. I.
No, he left.
DGJ decision.
So he can't, oh, he's down there. Okay. So this is one of the most complicated sessions because most of the people don't understand what they're talking when they're calling upon the issue on axillary procedures. So I call this usually the axillary confusion because people do not understand that whatever amount of lymph nodes you remove, your patient will not live a day longer. And the only issue is morbidity, morbidity, morbidity. And for those in the back, I just tried to give a little intro, that's all. So this is Sir William Halsted as he was aging. You know, we saw the very young picture from him. This was his idea, I mentioned it earlier. But regardless of the radicality, you see, it was not helpful. And then this in the middle is a picture. It's a young lady. You can see this easily. And that is taken, this picture was in 1965. Everyone should have known better. And you see the swollen arm and the humiliation to this. But even these days, when you have color pictures, the evidence is not traveling that much. That's one thing. And then we have seen Bernie Fisher, his theory, and we know this. Okay. This is, oops, this, I don't believe it. Okay, keep the lady away. So this is what we try to do. This is a map of the drainage of the breast. And we are just talking these days, regardless of the localization of the tumor, about the level 1, 2, and 3. When we started to be on our learning curve as young fellows, we learned to count the lymph nodes. And the more you had, the better surgeon you was. 40, 50, that was a good day, you know. And if you don't have that, you call the pathologist and say, you know, clean your glasses or put on the light on your microphone when you count the lymph nodes. And that was a procedure, what you can see here. This is level 1 and 2. The axillary vein is on top. And all the interpectoral nerves are gone, you know. So there was no feeling whatsoever, nothing that was harming, and that was the final result. I guess you know this. And then, do you know in which carcinoma Giuliano developed the sentinel lymph node? Does anybody know it? Exactly. You know, they show that. And you can see the very small little tracks down there. And that's all what you have these days. You know, that's all. So this is transferring clinical trials into daily routine. Okay. And now we are coming up with a alphabetic soup of whatever that is, you know. And we try to sort that out with the help of the experts who are showing what is meant by that. But this is a definition. So I've taken this from Jennifer Chang. He provided me these slides from her ESCO presentation 2022. But you see the sentinel lymph node biopsy is the identification and removal of a lymph node biopsy, a Soleil or 2 or 3 lymph node biopsies. An axillary lymph node dissection has been the removal of all lymph nodes, usually level 1 and 2. Nobody today touches level 3. Nobody. So then targeted lymph node biopsy is the selected removal of a metastatic lymph node. And therefore you have to have the core needle biopsy and the clip has to be in place. And when you get that tissue out, you have to have a radiogram to prove that the clip is removed. And then you have the targeted axillary dissection. Even if you have a sentinel if you have a positive lymph node, and you apply your radioactivity or blue dye or whatever you're going to do, you're combining both the sentinel lymph node biopsy and the targeted lymph node biopsy. So in other words, if that is a lymph node which has a clip and the radioactivity is in this one, that sentinel lymph node is negative, but your targeted axillary is also negative and you have a second lymph node. So what I'm going to say is that the lymph nodes have no hierarchical order, they're skipping around. And that's the difference, and this is where you confuse yourself with all the abbreviations. And this is what we all mean. Even if you have an ultrasound here, it doesn't mean that is a positive lymph node. It looks like that the pathologist has the last and only word. And the rest is well known to you. And this is what we call then a targeted axillary dissection. You're going to see that you have here down there. I mean, I don't have to read this to you. You have to have this lymph node. This is very nice in publications, but it's fitted for the picture. Usually you have whatever, 5 to 8 lymph nodes, and then on a good day, the clip is in that. Okay, and that is maybe the result of the session. You're going to see this and challenge our Oxford debatees about the management of the axilla after neoadjuvant chemotherapy. The rest is given. And we have also, the Germans make it a little bit more complicated. So we have it for every scenario, our recommendations, what you're going to do here. That is just to give you an idea. That's going to be a brain draining session. But at the end of the session, I think we have an idea what's going on in the axilla. And even here, less is more. So this was the topic of your presentation. Okay, that's my intro. And now it's up to you to call upon the stage the rest of the gang.
Dr. Rajiv Bhatt, who is going to speak for the sentinel lymph node biopsy post NSCT.
You bring your own laptop?
Yeah, unfortunately, I'm also afraid of the bell, but the slides didn't format properly when I transferred here. So you just excuse me for a minute. I'll just quickly shift the wires. Okay. I think that's good enough. So that's the general reaction of diehard surgeons when they talk about SLNB post NACT. De-escalation, horror of horrors, and certainly not. Because the thinking is that one size should fit all, axillary lymph node dissection in all cases. NAST is usually given in advanced breast cancer. But today's world is all about individualized treatment, and I'm clearly going to argue for SLNB post NACT or NAET, as you will. What is it that we know? Let's have a look at upfront surgery first. All patients with negative nodes will undergo a sentinel node biopsy. More than 2 positive nodes, they'll have an axillary node dissection. However, now omission of the axillary lymph node dissection is done when you have more than 2 positive nodes, increasingly in clinical practice, and there has been no difference in the oncological outcomes, and there is evidence to clearly show this. There is also omission of sentinel lymph node biopsy in select group of patients, those with stage 1 hormone receptor positive and HER2 negative tumors, and certainly in women above 70 years, and this is part of certain clinical guidelines now, although they're not easily accepted worldwide. We are awaiting the trials of these randomized clinical trial results. What happens in the situation when you have positive lymph nodes? All patients undergo axillary lymph node dissection, but remember that half of them will have 2 or less positive lymph nodes, which is the criteria Z11 for omission of completion lymph node dissection. CN plus, I would argue, is indicative of a higher nodal tumor burden. And we have this excellent ongoing trial which looks at targeted axillary surgery, mainly in the precise group that needs it, the hormone receptor positive and HER2 negative. Although they've covered all the subtypes, but about 70 to 80% of patients are hormone receptor positive, HER2 negative. And it's a non-inferiority trial looking at axillary lymph node dissection versus axillary radiation. And the initial interim analysis at 500 clearly showed that there was no difference. And this was a planned interim analysis. So the essential thing here is to perform a diagnostic staging procedure as well as therapeutic removal of nodal disease. And It's simply to reduce the nodal tumor burden selectively to the point that radiotherapy can control it. This is in fact one of the best ways of de-escalating using a biomodality treatment. So axillary surgery has evolved from being staging and therapeutic procedure to now SLNB being a staging and a therapeutic procedure. Axillary lymph node dissection always being mandatory to now not always being mandatory. And clearly we know why SLNB should be done. Morbidity is 30 to 60% of all cases of axillary lymph node dissection, however good the surgeon may be. Who will receive neoadjuvant systemic therapy in today's day and age? If you see the NCCN guidelines of this year, a significant number of patients, so all triple negatives, HER2 positives, more than 2 centimeters will certainly receive it. All node positive will receive it. All more advanced diseases will receive it. And in women where the breast tumor ratio is not favorable, will also receive it. So what this means essentially is that the majority of the patients in India are likely to be receiving neoadjuvant systemic therapy. Also remember that we have multiple biological types. You would have given the neoadjuvant treatment in accordance with the specific biologic type. So you have a host of multiple different treatments that have been given. The anatomical stages are different, the age groups are different. So essentially this is an extremely heterogeneous group. We certainly cannot club one size fits all approach post NAST for this precise reason. Now let's look at the 4 situations. Dr. Christian showed multiple situations in his protocol, but essentially we need to know 4. Initially node negative. Obviously now will remain node negative as well. Metastases are very infrequent. If there is a complete clinical response, then the chances of getting a positive node are almost 0. Sentinel lymph node alone in these cases is certainly enough, and there are 2 excellent trials that are looking now at omission of sentinel lymph node biopsy in these patients as well. So not only is sentinel node biopsy to be done, certainly not axillary, but now you're looking at omission of sentinel lymph node biopsy as a possible option as well in this group of patients. What about the CN plus that goes to YPN0? By YPN0, I mean by sentinel node biopsy. Now, look at the nodal PCR rates. We know that it differs depending on the biological subtype, with the maximum responses happening in the HER2 positive and the TNBC patients, and the least, of course, happening in the hormone receptor positive patients. The nodal PCR rates essentially reflect that, but the problem is with the luminal HER2 negative, where you have only a 26% nodal response rate. The pathological complete response rates in the lymph node and the breast are not always similar, and the total response rates are much less than either. So what this means is that your pathological complete response rates are independent of clinically or pathologically proven nodes. Irrespective of breast tumor residuals, the persistent lymph node involvement is what drives the prognosis. And persistent lymph nodes, if removed, are unlikely to alter that prognosis either way. So it is crucial to assess all lymph nodes histopathologically. Sentinel lymph node biopsy is not being advocated because of the fear of missing nodes. But is that a good enough reason just to do axillary lymph node dissection in every case? Let's look at the issue with SLNB. Giving of neoadjuvant systemic therapy alters the anatomy of the lymphatic system. And we certainly know that this happens with chemotherapy. Not so much, I'm not sure we have so much information with regard to endocrine therapy, but with chemotherapy, it certainly is the case with increased fibrosis and inflammation. And there is a heterogeneous tumor response. And we look at the false negative rate, and the issue to date has been that we've had a higher false negative rate when you do sentinel lymph node biopsy in patients who have received neoadjuvant systemic treatment. But this is evolving. You see, now the current literature, if you have removed at least 3 lymph nodes and pathologically examined 3 lymph nodes, the FNLR rate is well within what is an accepted arbitrary cutoff of 10%. And of course, if you add total axillary dissection 2 to 12%, you do the MARI procedure with radioactive seeding, then it's about 7%, and the RISAs, which is a combination of these, is even less at 3.5%. So that's as far as the yield of nodes is concerned. Sorry, yeah. Now, what about the oncological outcome? Because that's where we don't have the information, right? How does this translate into oncological outcomes? SLNB, total axillary dissection, MARI, there are multiple studies which have shown that with a follow-up period of up to 9 years, the regional recurrence rates are under 3%. This trial compared SLNB with total axillary dissection, 1,144 patients. Sentinel node removed 4, TAD removed 3. There was no difference in oncological outcomes whatsoever, whichever you did. But you submitted nodes to pathology. And this particular trial with the disease-free survival over 5 years, we showed absolutely no difference when regional node irradiation was added to patients who had sentinel or axillary node dissection. We are certainly awaiting the results of this trial, whether we can completely avoid axillary treatment in T1, 2, T3, N1 patients who have no residual cancer in the lymph nodes. Can you completely avoid any axillary treatment whatsoever? So that's where we are headed. And we can't take 2 steps forward and 1 step back and say that now all of these patients are going to need axillary lymph node dissection. Now, what about the last situation where you have positive nodes afterwards as well? Well, let's look at what you get when the pathologist examines. If you get isolated tumor cells, then clearly we know that this is not of significance and it doesn't mandate an axillary lymph node dissection. The data is very clear. So you're not justified in doing an axillary node dissection when you have ITCs. What about micro and macro metastatic disease, right? We know what micro metastatic disease is, less than 2 millimeters of disease in the lymph nodes. And additional positive lymph nodes are found in 60% of patients. The likelihood of finding positive nodes is not associated with the receptor subtype. So one is the biology, the other is what we are picking up on an anatomical basis. 3 randomized clinical trials, all the results are expected around 2030 to 2032. That means about 6 to 8 years from now. So for 6 to 8 years, are we going to subject these patients to axillary lymph node dissection? I don't think so, because we have sufficient retrospective real-world studies, also sub-studies from completed trials that have been done and that are ongoing. And I'll just give you 3 examples. Multiple small institutional studies, axillary recurrence rates 0 to 28% over a follow-up period of 9.2 years. The oncological outcomes in patients undergoing sentinel nodes, sentinel node biopsy and completion axillary node dissection versus sentinel node alone versus axillary node dissection, 630 patients, 51% received regional node irradiation. There was absolutely no difference in the oncological outcomes. And this was an international multi-centric retrospective cohort which looked at a particular subset of patients who had residual nodal micromets after NACT and the axillary recurrence rates at 5 years using ALND. We think that the axillary recurrence rates are going to be really high if you don't go in and do the axilla. As surgeons, it is no longer justified to think so. Let's await these results as well. Finally, the MARI study. The MARI study was very interesting in the sense that it prevented axillary lymph node dissection in about 80% of patients, and they did this with radioactive seeding, and you all know the trial. But the other important thing is that axillary recurrences occur at a median of 2 years following treatment. Right? So it's the initial period of follow-up that becomes critical. This question attracted much debate in the St. Gallen 2021. Panelists were asked, is axillary dissection required for residual cancer in lymph nodes after standard neoadjuvant chemotherapy? Look at the percentage of panelists who gave response. Macrometastases, about 70% said they would. The remaining either didn't vote or didn't agree. Macrometastases in 1 to 3 nodes, similar percentage, but micrometastases, less than 40% would go ahead and do a completion axillary dissection. And for ITCs, a small minority. So as far as I'm concerned, is SLNB justified post-NACT? In this situation, yes. Is it justified in this situation? Node positive goes to node negative? Yes. Is it justified in this situation? Node positive goes to microscopic node positive? Yes. This possibly is the only situation where I might grant that you can say we don't know. And either approach may be acceptable. But the bottom line is that in 2024, we have to tailor the auxiliary surgery. Nothing more, nothing less. Thank you very much.
I would like to call now Dr. Sanjit Kumar Agrawal to speak against.
Just hold on. Your clear statement is that sentinel lymph node after neoadjuvant with your 3 little experts. Okay, then it should be done. Yes. Good. Okay, so who's speaking against?
Yeah, he is there.
Come on. Do you have a scalpel? Okay.
So I will speak upon what we can do in India.
So make it loud and clear.
So it's looking fancy that this is the TAD data. So can we do really TAD? And what are the data of false negative rate of sentinel lymph node biopsy? And do we think for berry picking just like Texas trial? So we need to think what we are doing. So coming to the same topic, CN0 pre-chemotherapy. So if the patient was presented with clinically node negative disease and remained node negative post-chemotherapy, do we have sentinel lymph node biopsy data? So I must say that we have data. So there are two. One is Ghana French multicentric trial, and second is MD Anderson study. So number of the patients were fairly good. Identification rate was good, and false negative rate was acceptable. We have outcome data also by the same group, Ghana 2 study with the French group, 419 patients. In the same patient, 1 axillary relapse after 36 months of median follow-up. So if you ask me for the node positive pre-chemo, yes, we can do sentinel lymph node biopsy. Acceptable identification rate and false negative rate. Outcome data, we have robust outcome data in node negative patient. And this is our experience of doing sentinel lymph node biopsy in this group of the patient, node negative to start with. And we have done sentinel lymph node biopsy in 254 patients. The sentinel positivity rate is not 0%, it's 1.8%. But if you see the data of false negative, if you're doing a sentinel lymph node procedure, you will not find a correct sentinel lymph node in 5 to 6% of the patient. So I agree upon that we can avoid even omission of sentinel lymph node biopsy in this group of the patient. So this is more or less sorted out. But when we are talking about this group, sentinel in node positive patient, especially T1, T2, N1 and N2 disease, I'm not talking about locally advanced breast cancer. So N positive patient, given chemotherapy, converted to N0. So as per our data and as per the international data, if you combine together the triple negative, HER2 positive and ER positive and HER2 negative, 50% of the patient will have axillary PCR in this group, and 50% of the patient will have residual axillary disease in this patient, even if you're doing axillary lymph node dissection. So coming to, can we do sentinel lymph node biopsy in this group? So we have 3 validation trials. So these all 3 trial was done in the Western population. One is American, second is European trial, and third is Canadian trial. So what was the trial? So they have done sentinel lymph node biopsy and have done validation axillary clearance in all node positive patients converted to N0, and they have done sentinel. So see the result of all 3 trials. So number of patients is very good in the first 2, but overall false negative rate was more than 10%. So we don't know the acceptable false negative rate in post-ethnicity, but if we will extrapolate the early breast cancer data, the false negative rate acceptable is less than 10%. They have done the subgroup analysis. What we are talking about more than 3 lymph node, it was based on some subgroup analysis. So that was not primary outcome of that study. So FNR, when you are using dual dye, was more than 10% in ECOG study, 10.8%, and Sentina and SNFNSC study, it was less than 10%. When you are removing 3 or more lymph node, the false negative rate was less than 10%. And if you are removing clip node, the FNR was less than 10%. So these are the things we found from these 3 studies. So overall FNR was more than 10%. FNR was less than 10% in selected group of the patient. As per the SNFNSC study, I see in the frozen, 3 or more sentinel lymph node to be removed. As a surgeon, I can't say that I will remove 3 lymph node.
So we need to look upon our data. If we are doing sentinel lymph node biopsy in the post-ethnicity patient, how many patients you will remove 3 or more sentinel lymph node. So what's in our head that when we go and do sentinel lymph node biopsy, we try to remove more non-sentinel lymph node to match the number. So that's the thing, that's the bias we are introducing. We need to use dual dye in this setting. So many centers in the India are doing only methylene dye sentinel lymph node biopsy. So if you don't have the facility of the radioactive dye or ICG dye, you should not think for offering sentinel lymph node biopsy in this group. And we need to think for the clip node removal. What is targeted exit dissection? It was already explained. Targeted exit dissection is sentinel lymph node biopsy plus removal of the lymph node with the history of metastasis. So this is the famous trial by the MD Anderson group again. The false negative rate with the sentinel alone was 10.1%. Clip node removal was 4.2%. Sentinel plus clip node was 1.4%. Yes, you can clip the node, but how you will identify the clip node? As a surgeon, that's the trick. So how you will do how you can put the clip, but how you will localize that clip node? So you can use radioactive seed, you can use mag seed, wire and ultrasound was used, just like we are using wire for localization of the breast tumor. It was used for the axillary clip also, highly failed. 50% of the patient, you couldn't identify the clip node if you're using wire. Same with the USG. So we really need to think of what we are saying. This is the TMH Mumbai study. They have done the low axillary sampling. They tried to validate low axillary sampling in this group of the patient. And they said that low axillary sampling is working in this group with the false negative rate of less than 10%. But if you see the median sentinel lymph node removed in their data is 7. So if you are removing 7 lymph node, probably you are almost achieving axillary lymph node dissection. So how to reduce FNR 10%? If as a surgeon, I am sitting in the India and I have to do the sentinel lymph node biopsy or any axillary down escalation in node positive patient converted to N0, can we achieve it? So this is the dual dye. So FNR I quoted in the table. So if you don't have the radioactive dye facility due to legislation or cost issue, you can use ICG and can do it. Can we do IHC on the frozen as per FNAC study? So you know that IHC on the frozen is very challenging. It's costly and time consuming. So if you want to use IHC on the sentinel to say that it's micromets or ITC or as per the data, it will take 1.5 hours to report that frozen section. Are you ready to wait for that frozen section? Greater than 2 sentinel lymph node. We say that more than 2 sentinel lymph node, the false negative rate will be less. But as per the data, it's not possible in 50% of the patients. So you have started doing sentinel lymph node biopsy in a post-ethnicity patient. You have done sentinel lymph node biopsy, and you are honest in removing only blue or radioactive dye. In around 50% of the patient, you will not achieve that 3 number. So what you will do for that case? So that's a real challenge. Axillary sampling plus sentinel lymph node biopsy as done by the TMH group, but as per the data, median number of the lymph node was around 7. So it's almost reaching axillary lymph node dissection. Coming to the targeted axillary dissection, yes, targeted axillary dissection looks fancy, but do we have radioactive seed in the India? Still radioactive seed is not available in India. You can mark the clip, but how you will remove that clip? Wire. The false negative rate reported in one of the studies 0%, but it's very difficult and it has high failure rate. So the failure rate with the wire localization of the axillary clip is 1 out of the 2 patients. In America, they use GPS clip technology. The false negative rate is still not reported. It's easy, costly, it's not available in India. So as a surgeon, if you want to do targeted axillary dissection, in Indian setting, you can clip the node, but you can localize that lymph node by either wire or ultrasound, and both are not feasible as per the data. Targeted axillary dissection looks simple, but if you really want to do targeted axillary dissection, you need to think for many things. Which node you need to be clipped? So in axilla, if it is N1 disease, there may be 3 lymph nodes. As per the MD Anderson study, they said that you do the biopsy of the most suspicious node and you clip that node if it is coming as positive. What about rest of the node? So we don't know. So that TAD data looks confusing if you are thinking as a wholesome of the axillary thing. How you will do identification? You need to base upon as per the data on radioactive and mag seed. not available in India. German multicentric study itself, so the clip identification rate with the TAD is 86.9%. So you will fail in 12% of the patient in identifying clip if you are thinking for the TAD, even with the radioactive seed and max seed. Clip migration rate in the multicentric study is 2 to 30%. You can put the clip, but the clip may migrate after the nodal response. It's not the breast tumor, 3 centimeter tumor. These are the small nodes. And it's costly and it needs multiple additional procedures. Outcome data. Yes, we have some data about outcome data, but we don't have level 1 evidence. So if you see the early breast cancer data, Sentinel was based on some robust level 1 evidence of randomized controlled trial, but we don't have any evidence of post-ethnicity Sentinel with a randomized controlled data on this setting. We have some data of 5-year disease-free survival and overall survival, but these are all are retrospective data. To conclude, I will say that node-negative pre-chemotherapy patient, yes, we can do sentinel lymph node biopsy, but node-positive pre-chemo patient, still we need to think in India what we are talking about. So, means even if you are doing ALND, if you don't have radioactive and max seed facility, if you don't have good radiologist marking the axilla, TAD has certain limitation in India. It's not possible. Sentinel alone, you need to think for removing 3 or more lymph node. It will be not possible in each case as per the data of Sentinel in the center who are doing post-anesthetic Sentinel, post-anesthetic Sentinel. So at present, what we are doing at our center, we are almost in the completion of this trial. So what we are doing, we are trying to use blue plus ICG dye. So whatever the data was available is for blue plus radioactive dye. ICG has some inherent limitation because ICG is very sensitive. So what we end up in removing more lymph node. And what we understood with the post-ethnicity data that Sentinel alone in node positive is probably not sufficient. We need to remove little bit more node, either by targeted exit dissection or low exit sampling to reduce the false negative rate. So we want to use that disadvantage as an advantage with the ICG, and probably we'll come with the result in 6 months to say that this is working for us or not. So thank you very much, and I'm happy to answer any question.
I would like to call Dr. Rajiv Bhatt to rebuttal for 2 minutes. Only 2 minutes, sir. Dr. Agarwal, please stay on the stage only.
Right, 2 minutes. So I think the entire talk of my learned opponent has focused on the FNR rate. And the trials that he initially quoted were published more than a decade ago. Techniques were relatively new at that time. We now know he himself has shown the data about ICG and Joule dye. FNLR less than 10% is certainly acceptable. Most of it was around 9 to 10. One trial that he showed was 10.1. I think it's important that we move away from the idea that axillary lymph node dissection improves local regional recurrence. The NSABP04, way before the NSABP B32, questioned and challenged this precise premise. You have axillary lymph node, axillary radiation as an option. Most patients who receive breast conservation anyway are going to get enough scatter at level 1 that a lot of these nodes are already radiated. And ALND is not different from axillary radiation in terms of its outcome. Finally, I think he's talking repeatedly about the complexity of TAD and all that. Who said oncoplasty was simple 15 years ago? It's now standard of care, right? So even techniques evolve. They keep getting better. And as they keep getting better and get easier, more and more people will adopt it. And I don't think India is far behind on that. He himself said that you need to take more nodes. What does a low axillary dissection do? It removes a whole bunch of nodes. That's why it's showing similar results. My argument is that if you can actually pick up pathologically involved nodes by a combination of techniques, it's more than enough. You do not need to do axillary lymph node dissection. Thank you.
Thank you. Dr. Agarwal, 2 minutes for you.
So again, coming to the same thing. So TAD is difficult. Second thing is that in this situation in the TNBC in HER2 disease, it's not about curing the disease by LND. We all know that we are adopting the treatment as per the nodal response or as per the PCR. So if I am missing the information of that positive node, probably I am not giving adjuvant therapy to that patient. So if it is a triple negative patient, if it is a HER2 positive patient, node positive to start with, and converted to N0, and you're doing sentinel, and if your false negative rate is 15%, you are missing the information in 1 out of the 6 patient. And we really need to think that, do you want to add adjuvant therapy in this patient? You are missing capecitabine therapy or olaparib therapy in that group of the patient, and you're missing TDM1 therapy in that group of the patient by incomplete information. So auxiliary surgery in the post-nicety is an information also, and knowing that information well till that technique advance is very important.
Thank you. Dr. Christian, please conclude the session. Dr. Rajiv Bhai and Dr. Agrawal, both please come on the stage.
No, you're not released.
Yeah.
You are not
just-
released yet.
Can I just
make
get
a
from?
comment, sir?
Can I just ask you to give me the last slide from my intro?
I just want to make
No,
one
no,
comment.
you're the next I would ask. So what is the House
Okay.
considering? Please, your comment.
So my comment mainly was focused on, and then I think extrapolate to the debate here. When we talk of low axillary sampling or low axillary sampling as devised by TMH, the argument is that you are removing too many nodes, 6, 7. But we know axilla has 30, 40 nodes. So removing 6, 7 nodes should not be such a morbid procedure. When we talk about SLND, removing 4 nodes is good, 5 nodes is better. If you go 2 nodes plus becomes unacceptable. So I would say low axillary sampling is a good way to evaluate, and the systemic treatment and the radiation treatment that patient is going to receive is going to ultimately decide the outcome. So we need not be excessively radical with the axilla. We need to de-escalate, and if we are talking of low-cost solutions, low axillary sampling is I think, useful tool in those settings who cannot afford these fancy procedures.
Can I please make a couple of comments? One is, I request everyone who's addressing this issue of post-NSCT, sentinel lymph nodes, or management of axilla as a whole, please make a distinction of N1 versus N2 and N3. Because unless you do that, you leave much of the audience confused. There's a certain distinction between N1 and N2, which may revert back to N0. The very few studies which have reported on false negative rates in this setting, they all have very clearly shown, and I'm sorry that you did not quote the only Indian study which has been done by us, which distinctly showed that the sentinel lymph node identification rates and the false negative rates in CN2 or N3, which then converted to YCN0, were dismally low identification and 30% to 25% false negative rates versus acceptable identification rate of close to 95% and false negative rate of 6% or so in patient who had CN1 and became N2. Secondly, the definition of sentinel lymph nodes. Dr. Sanjeet, you may, I know that you were trying to make an argument against this motion. I know that you are much more knowledgeable than what you said. Sentinel lymph nodes are not simply blue or hot nodes. Today, the definition is you remove any nodes which are either blue or hot when you're using radiocolloid, or suspicious. Any node which is enlarged, globular, firm, while you're doing this dissection, sentinel lymph node biopsy is considered part of sentinel lymph node biopsy. And if you use that kind of a thought process, you will be able to get 4 nodes or more. It's not 3 nodes, 4 nodes, more than 3. 4 nodes or more, which can bring down your false negative rates.
So these were 15 comments. We just take them. Okay, thank you for doing this. So who has a question? Another comment? So then we come to the verdict, right? So this is something I think there's no question and no negative. That's an easy cake. Could you agree on the way in a CN plus, and you see how complicated that is? CN plus is not an PN plus. And the minute you are just training yourself that you have a suspicious lymph node to have a clear evidence, then you should do a core needle biopsy. If you can biopsy small tumors in the breast, then you should do this as well. And then you have created facts. So what Dr. Cheng was suggesting here, and this is again oncodiplomacy, I cannot work with that. Good response and suboptimal response to neoadjuvant. But the flow here is targeted axilla dissection. If that's negative, no more touching the axilla. If that's node positive, and I think that's the acid, then you have to have an axilla clearance. But nobody is telling you that you have to have 10, 15 lymph nodes out of level 1 and 2. And what I think is very complicated, that you upgrade, some lymph nodes to sentinel lymph nodes just to have the count of 4. So this is a statistic that doesn't make any sense. Just to avoid the number of lymph nodes, I mean, if you have a positive axilla and you have just one negative or one positive, that's not enough. So you're digging in the axilla and you mismatch the sense of sentinel lymph node. The sentinel is one who is just sitting in front of the axilla to protect the axilla. This is what a sentinel is. That's one point. So I think we cannot work with this. You have to have facts, and this is what we try to do here. So let's start on the top. No, that's not showing. Can you forward the slide here on the screen? Okay. So you start with C and 0, and I think we are clear here. And then in the middle, you have the result after your neoadjuvant chemotherapy. And you have everything what the two discussants agreed on. So if you have a C and 0 neoadjuvant and you make your sentinel afterwards, no more axillary when it's the top one. The discussion is, and our recommendation grade is plus minus. You can do it, but you can leave it just to the radiation person. And then if you have micrometastasis, we are stating this year, based on the evidence, to offer the patient an axillary dissection, and then you have macrometastasis, you have to do an axillary dissection. If you have a CN+, this is what you are discussing in this session, we would recommend to prove this as a PN+ sentinel lymph node by core needle biopsy and clip it or mark it, put a GPS, whatever you want to do. And then after your neoadjuvant chemotherapy, if you have a YCN0, so nothing in the axilla, you can read it by your own. But the problematic issue is when you have still a positive lymph node in your post-neoadjuvant axillary mapping, or how you call that, you should do, based on the evidence, I would say, limited axillary dissection to be sure that there's nothing else going on in the local control. So this is what I guess is a good way to do this. It's still a controversy, but we have to see, I think as far as I know, nobody is recommending a 2-dye procedure. One is fine. And I think with this, we should leave it. I really thank you for your extensive workup of the data, but there is no red or blue or black and white here. This is a dynamic process, and we have avoided so much unnecessary surgery and harming the patients in node-negative disease, and we should be really a little bit cautious to see if our good results are not jeopardizing if we are too quickly transferred on nodal involvement in the axilla. We're not talking about microscopic disease and maybe the very small isolated cells. If you go back and read the ACOSOC 0011 trial, there was no immunohistochemistry. It was just H and C. And so we're contaminating all our evidence. And this is again, that's a trial, not fully recruited, early termination, but it's again changed our practice. So I think next year you have to have the final discussion on that. Okay, thank you so much.
Yeah, thank you, the debaters, both of you. It was a very interesting debate indeed. And thank you, Dr. Christian, for the concluding remarks. So next we'll move forward with the panel discussion. on systemic treatment in HER2 positive early breast cancer. The moderator, Dr. Sachin Trivedi, I would like to invite him. So the panelist for today's this panel discussion is Dr. Priyanka Patel from Surat, Dr. Ekta Wala from Ahmedabad, Dr. Bhavesh Parekh from Ahmedabad, Dr. Ashutosh Mishra, Delhi, Dr. Kaushal Patel, Surat, Dr. Ravi Teja, Hyderabad, Dr. Christian again.
I don't. But, I think I'll manage.
So the first Priyanka and Avish, medical oncologist.
Okay.
Ashutosh is a surgeon. And this guy seems to be the only surgeon in the group.
Okay. No, Christian Jack is.
Yeah.
He's not. He's on my side now. Professor, you are a medical oncologist for me. Okay. So so while I was driving here, I just remembered not so long ago, I was driving down to see a patient in the outskirts of London. This lady was a very well-connected Indian of a very famous personality. And she was diagnosed with the breast cancer. And I went to see her, and you know what she said? Doctor, can you talk to my doctor in India? Because I think that doctor knows the best what is good for me. So I asked her, of course. So she got me two things. One was a phone number, and the other one was, Barfi from Kandoi in Ahmedabad. Yeah. So she connected me to Dr. Vijay, and I spoke to Dr. Vijay because you remember Dr. Vijay? You remember this lady we spoke when I was in London? Yeah. So this patient, young lady, 30 to 33-year-old, diagnosed with early breast cancer, HER2 positive disease. And she wanted me to talk to you because she believed that you were the best doctor in the world, and we had a lot of discussions about how to treat her the best. And it occurred to me that actually having breast cancer, early breast cancer, for anyone is a tragedy in some ways, but for a young patient it can be really difficult. Okay, and now, because I think we are discussing about beyond the scalpel, the topic of this meeting, what we thought, in the discussion about systemic therapy for HER2 positive early breast cancer, there are lots of things we can discuss about, new adjuvant, extended adjuvant, escalation, de-escalation. But I think what we did was we tried to confine our discussion just to the new adjuvant bit. A lot of things that I wanted to discuss have already been discussed. So what we'll try to pick out some certain gray areas and see what the panel thinks and what everyone else feel about it. So I just want to, start. Oh, by the way, these are not my slides. These slides were provided to me by Roche. So thank you so much for doing the hard work for me. So let me ask Dr. Ashutosh on the panel here. What % of your newly diagnosed HER2 positive EBC present with?
It's 0 to 10%, somewhere in between.
10%.
Yeah.
And Dr. Christian, in your population?
I would guess it would be, the same thing, 10, maybe 15%.
Yeah, so, and then Dr. Mansi, the data you presented, the numbers, I think, were 24% HER2 positive? 20%. So, is there...
but there is a caveat of T2 and N plus.
T2 N plus.
Yeah.
And if it was just HER2 positive patients?
Yeah, then it would be 15 to 20%, I think.
Yeah, so I personally feel that actually, do you think, Dr. Christian, that in our European, when I was working in Europe, I used to, quote a number of 15% or about 10% around that figure. Do we think that in Indian population, the chances of getting HER2 positive breast cancer is higher? Anyone else on the panel?
I think it's 20%.
20%. Okay. And how many of these patients are being offered neoadjuvant chemotherapy, Dr. Ravi, in your experience? Not in your practice, but in your experience when you see in general?
Now, as NCCN guidelines, any HER2 positive, especially you mentioned T2N plus, we are offering all NSCT.
Okay. So now T2N plus, okay. Now let me talk about the criteria on how we are deciding the neoadjuvant chemotherapy. So this is, I've just pulled it out from ESMO. So my one question to you is, T2 but node negative, okay. We all agreed in previous discussion that we'll offer them neoadjuvant chemotherapy. But what happens to patients who have 1.9 centimeter?
So at AIMS New Delhi, we are offering treatment NSCT more than 1 centimeter still.
You as well?
Yes, sir. Definitely rarely see patients with less than 1 centimeter in my practice. So more than 1 centimeter, definitely I would offer neoadjuvant.
Everyone.
Yes.
And is that a new change, or is this something that you have done after seeing some data in last few?
No, sir. Previously also we used to do the same thing.
So Dr. Christian?
I mean, we have these situations where you are not quite clear, you know?
Yeah.
And as I mentioned this a couple of times, the only one who can tell me the truth is the pathologist. So if I'm not sure if there's a tumor that is more than 2 centimeters in size and all my images doesn't help me, I have to do the surgery and get the tumor out, and then I have to think about it.
Okay.
So I think this is exactly the line, because the therapeutic impact is not that little. You know, I guess that you're touching the recent analysis of the affinity trial.
Yeah.
This is helping us not anymore because it's mainly focused on the node positive ones.
Yeah.
So I think in this situation, even if I prove myself wrong, I would go for this primary surgery to be sure what risk of recurrence I really have in this situation.
Okay. So, you know, Dr. Christian, in your presentation and in subsequent discussion also, you pointed out many times that in some ways, the primary aim of neoadjuvant chemotherapy is to do in vivo sensitivity. But, you know, we medical oncologists, you know, we love neoadjuvant chemotherapy, by the way. We like to believe, Dr. Ekta, do you agree? We like to believe that we are helping surgeons in some way by allowing them to do a good surgery, because that is the kind of discussion. You know, no, this is our, when we counsel the patient for neoadjuvant chemotherapy, what we actually as medical oncologists say that actually, yes, this will allow us, give us a lot of information and other things, but we think that if we shrink the cancer, we will facilitate a good surgery for you. This is how we counsel. What do the surgeons think? And I'll let Dr. Ekta also answer what she thinks.
So I think, yes, there are certain definite advantage with NSCT that surgeon can do BCS if they would otherwise not be able to perform because of the breast size to tumor ratio. And ultimately the main goal is to see response rate or to see the PAT-CR and further change in the treatment. So in my practice, I prefer NSCT for those patients who are more than 2 centimeter, but not if patient is less than 2 centimeter. I think upfront surgery, and we have a very good data of APT trial that survival is more than 95%. So I keep upfront surgery for less than 2 centimeter patient and NSCT beyond 2 centimeter, and other definitely in more than 3 centimeter patients.
Okay. Dr. Ravi, do you think we help the surgeons in any way by shrinking the tumor, or is this, if it is 2 centimeter, 2.5 centimeter, doesn't really matter?
So for tumor, whether it's 0.5 centimeter or it's 4 centimeter, if I am doing oncoplastic breast surgery, then it hardly matters for me.
Okay.
If tumor is 8 centimeter size and to node disease, patient want breast conservation, then definitely it's helping me out. Otherwise, up till 5 centimeter, 4 to 5 centimeter hardly matters.
Okay. So that's good to know.
Here is that, as doctor told, that it is what's the therapeutic implication.
Yes, but
that is most important.
See, before we got the TDM1 data, we only were able to prognosticate, right? It is now
in recent years that we are able to change the treatment. Before we got that data, what we did was we just told, we knew what was going to happen in future. Of course, neratinib was there, but it is only after the TDM data that we are able to say this. The previous line that we used to take as medical oncologists was we will shrink the cancer, we'll try to facilitate good surgery, but like you said, now it obviously things.
So
go
if
on
it
and-
is 1.9 centimeter and it is not negative,
Hmm.
then as a medical oncologist, if the patient comes to me, as you rightly tell that I first offer or ask my surgeon, are you going to operate this patient? Because I feel that to eradicate that tumor at 1.9 centimeter not negative also is a very important therapeutic implication to the patient also.
Okay.
So maybe we might consider that based on the data from Sarah Tolaney, we only have evidence for those small tumors, 2 centimeters, node negative. This is a kind of an exclusion in terms of escalation or de-escalation of systemic treatment and the anti-HER2 treatment. So in one of our introduction slides of our AGO, the German recommendation is whenever systemic therapy is indicated, you should use it upfront from the reason I mentioned. And I think it's quite a problem, even if you're a very skillful surgeon, and we heard this very nicely this morning, the amount of tissue that you just have to move around depends on the surgical volume and the techniques, and I would actually think that everyone who's doing neoadjuvant therapy is helping the one who's doing the surgery. So
Okay.
I take that for granted what you were saying. This is why we heard very nicely that you need this multidisciplinary approach.
Agree.
That, that the evidence is suggesting what you should do and not the eminence. When the most senior guy in the room is always the one that says, okay, it is so, and the team says, yes, it is so, Your Honor, then, doesn't make any sense.
Okay. Now, we saw the data that Dr. Mansi presented. Dr. Priyanka, in your experience, what percentage of patients with HER2 positive EBC achieve PCR after NECT?
I would say 40 to 60% matches with the available trial data. And if my patient is receiving dual chemotherapy like taxane, carboplatin, and trastuzumab, then the pathological CR rate incidence would be around 40 to 50%. And if they are receiving Phesgo plus chemo, like dual HER2 blockade with chemotherapy, then it ranges around 60 to 65%.
So there is about 10% difference if
Yes.
you do dual blockade?
Yes.
Do we all agree on that? Okay. Now, I think, what Dr. Christian, you were trying to point out, and we had an earlier discussion about the importance of MDT. See, these guidelines, and every guideline we keep reviewing, but ultimately it is a decision as a team, as an MDT, on what is best for the patient and giving patient the option. So like you were mentioning, I think what we have been practicing and what I practice as well is give the patient the best possible option upfront, give them a choice, and then, they make a decision based on their ability, whether they can afford it or whether they have access to the kind of drug and the facilities that might be available. Now, my colleagues from Dr. Ashutosh, what is the setup like in your institution? Do you have a dedicated breast MDT or you've got a general MDT?
At AIMS and National Cancer Institute, we have DMGs, breast DMGs. We have all these things along with this genetic counselors, and we have dedicated genetic familial clinics as well. So all sort of facilities we are having on those clinics.
Dr. Bhavish, do you have access to a psycho-oncologist?
He's Dr. Kausal Patel. I am Dr. Bhavesh Parekh.
I apologize.
Dr. Ravi, but I am Dr. Bhavesh.
I apologize.
So psycho-oncologists we don't have.
No. So, I think one of our colleagues was making a point about patient dropping out from the TDM1 treatment. I think as a medical oncologist, what we find is you really need a whole team of people to hold the patient's hand through the toxicity of the treatment. Because, sometimes it is very easy to give up and, patients keep calling you with, thrombocytopenia, they've got admissions and, you're very busy. But if you got a dedicated team, including a psycho-oncologist, and explain to the patient that actually these are short-term pains for long-term gain, with some dose adjustment and dose escalations and de-escalation that we spoke about earlier, Dr. Christian, I think the patients actually end up getting a reasonable, length of treatment. So that one part I think was missing in previous discussion was about the importance of the supportive care, which I feel is extremely important, especially in early breast cancer patients. So, okay, a very, very important question now for all my medical oncologist colleagues, one by one, please. What is your preferred choice of NACT in this patient group?
It's a TCHP.
TCHP?
Yeah.
For you?
Yes, sir, definitely TCHP. If the patient is not affordable per pertuzumab and with the hormone negative, I'd prefer anthracyclines.
TCHP.
So you said hormone receptor negative, you prefer anthracycline?
Yes, and if the patient is not affordable for pertuzumab.
Okay. Okay. So you mean anthracycline and Herceptin?
Yes.
Okay.
With taxane.
Fine.
TCHP.
So I think TCHP to all my patients.
Dr. Christian.
I think even the NCCN mentions only TCH and TCHP.
Yes.
Anthracycline may not be any longer after the train 2 data.
Exactly. So I've got that
Because
data
one of the
here.
previous speakers also mentioned that he would prefer AC with TH.
Yeah. So anthracycline and taxane, that was our kind of go-to word that we used to teach to all our, trainees and students. That exposing all breast cancer patients to anthracycline followed by taxane plus minus targeted therapy would give you the best result. But after this data, things have changed. Dr. Christian, are you still using anthracycline for these patients?
We have the alternatives, 12 times paclitaxel and then EC 4 times every 14 days, or the train 2 data is not the same level of evidence because it's not so we do not have a confirmatory trial on that. So in our guidelines, this has a 1+, and the other one still has a double plus. We see this in some regions that people, as it was mentioned previously, that they would like to avoid the over-expected cardiac toxicity. I think that's a fair option of doing this. It's not my first choice, but it's a fair data and it's a fair option, and the data are as they are. So you cannot withhold this information from patients who are concerned about their cardiac toxicity.
Because biologically speaking, my preferred, if a patient was ERPR negative and HER2 positive, I would be thinking of exposing them to anthracycline. It was the opposite of what you mentioned.
Even the data of the TRIFINA study shows that with omitting the anthracyclines and using dual anti-HER2 therapy, it's a more PET-CR compared to the anthracycline.
Yes.
So nowadays, if we are using a dual HER2 blocker, then it's definite we can omit anthracycline from our regime. If we are not using dual anti-HER2 therapy, even though then we can omit the anthracyclines from the regimes in HER2 positive patients. Because of 2 reasons, the PET-CR in neoadjuvant chemotherapy with adding anthracycline is not so significant difference. Second thing, we can omit the cardiotoxicity of HER2 blocker as well as anthracycline.
So, I've been using TCHP for ERPR negative, HER2 positive, and I'm still not 100% certain whether to use the same combination for ERPR positive and HER2 positive.
Actually, in one of the meta-analysis for PCR, that is, I think, if I'm not wrong, NeoBC meta-analysis, they have shown that the PCR rate for hormone negative, especially with the TCH, TCHP, and anthracycline followed by TH. Anthracycline followed by TH has more PCR rates than TCHP and TCH in the hormone negative subset.
Okay. So this is the data that actually compares the anthracycline-based treatment versus the TCHP, and it is quite good actually. I mean, I must say that this gives me some food for thought even in ER/PR positive, whether it is time to switch the practice. Now, like you said, even in the NCCN guidelines, TCHP is actually become the standard. And once upon a time, if you use carboplatin for ER/PR positive, you were looked down upon why you're exposing patient to carboplatin if they are TCHP. Just one very important thing, Dr. Christian, whether you'll be able to comment on this. The reason I am actually wary of changing my practice very quickly is for some of the data and graph I saw before trastuzumab and targeted therapy came into picture. So ER/PR negative, HER2 positive was worse than ER/PR positive, HER2 positive, which was worse than triple negative when it came to risk of local relapse and risk of recurrence. What is your thought on that? Is that a true interpretation of survival data from before trastuzumab?
So this is a wide travel observation. If you look at these data, you see that the availability of the treatment in the given groups are not consistent. But it's not a big surprise that ER/PR negatives are behaved different. You see this in the endocrine, luminal A, luminal B. They're different. The peaks are very early and very late, and just the opposite side around. That was Ms. Safna showing these data. And so it's an observation. So I don't have a clear information. If you have a look and then on the triple negatives with the most updated treatment, you're going to see if the data are still the way we all read it,
Yeah. So I used to use that graph, and like you said, this is an observational data, but actually, it actually emphasizes how much difference invention of trastuzumab has made to the lives of patients. Now, in the Indian context, we actually spoke about the cost, and our colleagues from various organizations commented on the availability of the drug, but also the cost. So you see, I know it is a very expensive drug, the combination dual targeted therapy. With these patient access program, do you think our Indian colleagues, do you think, Dr. Bhavesh, is the patient uptake getting better with this the patient access program that are being offered?
Yes.
Yeah.
Sure. Patient assistance program is very important as far as the HER2 anti-HER2 treatment is concerned. More and more patients will accept, and more response and more durable response we get.
And one very important observation I had in the Indian context was actually there are lots of patients who have access to the state government and the central government schemes, which actually allows them to use this. But I am told that if you are on those schemes or if you got insurance, you cannot access patient access. Is that right? Roche team? Yeah, that's right. Yeah. Any thoughts about changing that? Because for CGHS and people who've got government schemes and other things, because there are chief medical officers sitting in various areas, they come back asking question, why are you prescribing such expensive drugs? And in fact, if they have to go for this, they have to buy the treatment. I don't know what my colleagues have observed in their practices.
Yes, sir, definitely. If it is CGHS or central government sponsor scheme, they are not providing the patient assistance program. But it is a state medical program that we have. They are providing a trastuzumab for free, and the patient are able to get pertuzumab from the Roche.
Okay. So,
and if the treatment is standard, then CGHS is accepting all these requests.
They are accepting. Okay. Now this is the last couple of slides, and then I'll just allow anyone to make a comment. What is the choice of your treatment, medical oncology colleague, if patient have received complete pathological response?
A single agent trastuzumab.
PCR.
Yes. If PCR is there, then I would like to go with the trastuzumab.
Okay. Dr. Christian,
I just showed you the paper that that is not the best option. I mean, if you started with a dual blockade and you have a PCR, you should continue with that. So there's no data that de-escalation to single use is adding any benefit. So if you have the chance to use it, do it. You know, after PCR that is induced by a dual blockade, I would use it for the continuation of a year. This is something what was traveling nicely, but there's no evidence for that you are doing better. If you don't have the chance to offer this post surgery, then you have to use trastuzumab. But if you have the chance to use both, I would definitely continue with the same regimen.
Because we don't know which drug has worked. So I continue pertuzumab in my practice, specifically when patient is affordable.
yeah, you're right. There are a lot of biological aspects to why we make the decision. But my feeling is that if something is working, why do you want to change it? You just
And
carry
the same,
on.
we are following our aims. If we have started with dual targeted, then dual target. And
Okay.
recently, we have also started an RCT, trastuzumab plus capstabine in PET-CR.
Okay.
Okay, so we'll see the result in coming future.
Fine. So that brings me to the patients who have not achieved complete PET-CR. So Dr. Priyanka.
With the availability of Catherine data, definitely, if my patient is not has not achieved pathological CR post neoadjuvant treatment, then I would like to put her on Kadcyla.
Okay. So I'm just sharing the graph that we've already seen. Yeah, that this is now the standard of care. Anyone who's not achieved PET-CR, and that discussion we've had few times, whether 1 cell, 2 cell, 10 cells, it doesn't matter, because when you do CPC analysis, more than 4 or more than 8 cells in 10 ml of blood is more than enough to tell you that there is circulating tumor cells, and they might actually give rise to tumor. 1 millimeter of tumor actually might have hundreds of thousands of cells, if not more than that. So it doesn't make any difference. You should actually change the drug. Now, one very important point that Dr. Christian was making was, see, we use PET-CR as a surrogate to tell what the overall survival might be. But there is a big section of patients who may have had PET-CR but may not do very well. And there is a ESMO, I think in one of the ESMO webinar, I think one of your colleagues from Germany has been presenting the data about those genetic markers that might be able to help us decide which are the patients that may have responded but not actually do very well in future. So I think future is going to be doing a lot of genetic studies and have different predictive model based on the genetic data. And I think I'll ask the last question to Dr. Christian, and then we'll end. Dr. Christian, we were doing a trial of TDM1 plus immunotherapy. Have you been any part of any study with that, or what is your experience?
So there are so many trials out there combining this. This is always, when one drug works, people are just going to this cocktail bar and create the next cocktail and the next and the next, and maybe it's a lucky shot. You're going to see this. Mostly important is the amount of dose reductions. How many long pending side effects are you kicking off? I don't know.
Yeah.
And you have to have from small phase 2 trials some evidence that there's a mode of action that is additive or even better synergistic. I will tell you this tomorrow, that in HER2 positive disease, if you do the right analysis, you're going to see also that there's an immuno-hot and immuno-cold situation. And we've seen that. Edith Perez was showing this a couple of years ago that in immuno-hot tumors, you do not need dual blockade.
Yeah.
But these are very small numbers, and I would not make a big cake out of that. So it's, if you combine all these side effects and you treat those patients what you and I do, then we see that we induce so many side effects, and the the checkpoint inhibitors, really, this is not a simple and easy drug. And we have to see the context where we're going to do this, you know, just to push up the neoadjuvant couple of percentages up, and you have dose reduction, all this stuff. It's scientifically very interesting, but that would not be my standard of care. And even if you have the data from all these exclusion criteria, and then the patient is sitting in front of you, you know, she has so many contraindications that you're using this. I think we heard this very nicely. If you say no to the future, there is no future.
Yeah.
So we have to wait for the data.
Okay, I think with that, I'll let everyone escape and have their cup of tea. So thank you, organizers. Thank you, Dr. Vijay, Dr. Mansi, for inviting me. Thank you, Rosh. Thank you.
Thank you, Dr. Maitri and Dr. Nikunj, for the session. We will continue with the next session, which is the panel discussion on toxicities of anti-HER2 therapies. And for that, the moderator is Dr. Pallavi Ladda. I would like to welcome her on stage, please. Thank you. Meanwhile, the tea is served. Please help yourself.
Okay.
Good evening, everyone. I will like to call my panelists. Dr. Santosh from Hyderabad, Dr. Nandita from Hyderabad, Dr. Karthik, Dr. Sujana Priya, Dr. Kinjal Shah, Dr. Sadvik, and Dr. Jackie, sir. So after Dr. Sachin sir spoke about the systemic therapy in HER2 positive EBC, now we should talk about the toxicities. What are the toxicities which happen for anti-HER2 new therapies? So this is a hypothetical case. What we generally see in general OPD, 49-year-old lady, diabetic, premenopausal, carcinoma right breast, 6 into 5 centimeter lump, histopathology invasive ductal carcinoma, grade 2, ER 15%, HER2 new 3% with axillary node FNSC positive. PET CT done, which is non-metastatic. Then what is the plan of treatment? Can I ask Dr. Karthik, what is your plan of treatment?
So in this patient, we'll go for neoadjuvant chemotherapy plus dual HER2 targeted therapy. That I'll choose trastuzumab, pertuzumab with docetaxel and carbo.
So everybody agrees that we will use HER2 new directed therapy. Is it? Okay. Dr. Sujana Priya, what is the most common adverse event that you see in your early anti-HER2 new therapy in early breast cancer?
So I'll be worried about the cardiotoxicity. So I'll be inclined to do a 2D echocardiogram. So before starting in routine blood investigations, anyhow the workup is done. So that is the minimum I'll be worried about.
Okay. Dr. Nandita, anything addition you want to tell?
Yeah, I think with the anti-HER2 therapy, that's the main concern. Pertuzumab, I suppose, adds to diarrhea as well in terms of toxicities.
So nowadays we are using TDM1 also as an adjuvant in early breast
with
cancer if they are
TDM1,
not responding.
you will be pretty
Anything,
much
Dr. Kinjal, you want to add upon toxicity per se to TDM1?
So specifically TDM1, apart from the cardiotoxicity, TDM1 has the specific side effect that is thrombocytopenia, which is different as compared to other anti-HER2 agents. So if we are planning a TDM1 in a patient, if she doesn't get a PCR, I would also consider the thrombocytopenia and check the platelets accordingly.
Dr. Santosh, most common adverse event you see in the MBC. Can you enumerate, and is it different from the EBC? Early breast cancer is different from the metastatic breast cancer.
Yes. So metastatic breast cancer, we have the advanced disease. But one thing I want to bring forward is the cardiotoxicity, which we often discuss with dual HER2 targeted, is not so much there with the stringent follow-up we keep. So the main worry is the other toxicity. So even with the person who has borderline cardiac function also, with global longitudinal strain monitoring and doing echo, we can administer dual HER2 targeted, even with the ejection fraction of 45 or 50 also. With careful monitoring, we can give. And it is many cases reversible. So with good follow-up of echo, that is not a practical problem. In this scenario, the patient being diabetic, whenever we give Taxol, we add some amount of steroids. So uncontrolled diabetes is what we see. And yes, whenever we have dual HER2, the diarrhea is main problem that I see more. Very rarely I see infusion reactions and chills that are very minimal that subsides. And transaminitis is something that we see with TDM1 that trouble us sometimes. And there also I see some difference between the generic and original, where the generic has more diarrhea and more thrombocytopenia compared with the original Catzilla. These are the difference. In MBC, the toxicity as per diarrhea is little bit more compared with EBC. That is the difference I see.
Dr. Sadhvik, how many percentage of the patient will discontinue the treatment in EBC with cardiotoxicity?
With the dual anti-HER2 trastuzumab and pertuzumab, if you look at the data-wise, the amount of discontinuation is very less. It is less than 5%, if I'm not wrong. But in my personal practice, I've not discontinued any patient because of a cardiotoxicity. I had situations where the EF had gone below the baseline, the lower limit, and 15% drop. But then with cardiac monitoring and their treatment, I was able to re-challenge in most of these cases.
Okay, so you are not seen single patient of stopping the drug?
Discontinuation, no.
Okay, so you will restart again. We'll discuss that again. So what is the modality you will use, Dr. Raghuram?
Modality for what?
For monitoring cardiotoxicity. Specifically, I want to know if you are using the method, why you are using that method only actually?
I routinely use 2D echogram for monitoring a baseline 2D echogram, which has a JLS scoring as well with it. And also in follow-up scans, I follow up with 2D echogram. If patient is symptomatic or anything, in that case, I use NT-proBNP as well. But cardiac MRI and Muga scans is not what I'm routinely using.
Dr. Karthik, what is your practice? So nobody use MRI cardiac or nobody use Muga scan actually. Anybody has experience?
So at AIMS, when I was a student, cardiologist has a huge workload of other things. In that scenario, we used to do Muga scan also instead of 2D echo. But after coming to private practice, I'm doing 2D echo. In only those patients who are borderline and diabetes, I would ask the cardiologist to do GLS, or else other scenario, only 2D echo without any GLS. That is sufficient.
Okay. Dr. Kinjal, why you want to avoid Muga scan specifically? Any reason to avoid Muga scan? Because most of the trial shows that Muga scan is one of the good modality to use that.
So specifically in our setup, first of all, the cost will be an issue. The scan technique, so it is not always available in all the institutes, while the 2D echo can be nowadays done bedside also. And it is 2D echo is an easy, accurate, and we are all very comfortable while patients following with the 2D echo and all. Considering those things, I think we are not using Muga scan much more.
Anything addition to that? Radiation exposure is one of the
Yes,
things where
correct.
we want to avoid that actually. So biomarker, Dr. Nandita, anything about biomarker you want to add, or whether you will use biomarker in any situation?
Not specifically. I think studies have showed that troponins and things are not exactly predictive. GLS, in fact, is a little more sensitive. But in general, NT-proBNP is used by physicians and cardiologists as a marker of early CHF. So I suppose if somebody is on that borderline, you could use that as a marker.
Yeah, biomarker along with other studies like 2D echo, you can combine and then give a accurate. So I am asking basic questions because day-to-day practice we will do this only, and why we are doing this we will discuss that only. So Dr. Sadhvik, you will do every 3 monthly, 2 monthly, 2D echo routine. You told you are doing 2D echo in your practice. So
3
some-
monthly is what I routinely do.
Okay. Anything different practice for you, Dr. Santosh, between adjuvant and metastatic? Because somebody is on metastatic, how frequently you want to do? And yeah.
So I do after every 4 cycle, that translates to 3 months and all. So as per the guidelines, when we see the monitoring of 2D echo and adjuvant and metastatic, in metastatic, they do not ask to monitor 2D echo. That is what the guidelines say. But in real world practice, in metastatic setting, I do once in every 3 to 4 months 2D echo. Any symptoms, do as per requirement. But if asymptomatic, going smoothly, once in every 3 to 4 months.
Dr. Srujana, anything you want to add in this?
Nothing much. I mean, I would concur with the panelists on monitoring, except for the fact that if the patient is a cardiac patient or any high risk patient, or if he has an event, and or if the or ejection fraction is going down, then probably we'll do it more frequently.
So baseline, everybody wants to do baseline. Everybody you will do echo. Even young patient also you will do.
Yeah.
So same thing. Guideline says baseline, and then every 3 monthly once, and even after finishing treatment also. And as the Dr. Santosh correctly pointed out, for metastatic guidelines say it is whenever required or whenever patient is symptomatic actually. So now can Dr. Santosh tell me in your practice how many heart failure you saw? This is the busy slide, just I kept for a data, but in practice, how real heart failure you saw and you discontinued the treatment for that.
So if I see from my student days until now, over 7 years, so possibly 1 or 2 patients only, that would translate to less than 2%. Matlab, if
What?
we see,
That is a
so those cases are symptomatic thing, matlab, symptomatic heart failure, maybe 1 to 2%. Asymptomatic EF decline in another 1 to 2%. So combined together, less than 5% is in my practice of 7 years.
After this TDM one, any things has changed?
No,
change.
nothing.
Okay, agreed with this. This data just to in NSABP B31, there is a 19% discontinuation rate, and as Dr. Santosh pointed out, the rate almost is same, like 0.8 and 4%, which is symptomatic and asymptomatic. The rates are totally different. So let us move on. We'll discuss next thing. So suppose somebody comes to you in heart failure, Dr. Kinjal, what you will do?
So first of all, if the patient is symptomatic, I will immediately stop the trastuzumab. I will send the patient to cardiologist. We'll get in a 2D echo, and if required, troponin I. If the 2D echo is showing ejection fraction drop of more than 10% of whatever that was in baseline, or if it is less than 50%, that becomes a contraindication for further trastuzumab as of now. We will start here on some ACE inhibitor as well as some beta blockers, and we will regularly follow up for the symptoms. Once the patient becomes asymptomatic, I would like to follow up that patient with the 2D echo every 4th weekly. And if there is an improvement in the ejection fraction and patient is asymptomatic, I would re-challenge with the trastuzumab.
Good. You told about the treatment also. Dr. Nandita, adding pertuzumab, any cardiac toxicity will increase because we all spoke about trastuzumab and pertuzumab combined cardiotoxicity. Any thought on that? Okay, adding pertuzumab to trastuzumab, whether cardiotoxicity will increase or it's same?
I think that trifina, which looked specifically at cardiotoxicity in by addition of pertuzumab, did not show a significant difference in the 3 arms, but there was a slight difference in the neosphere, I think by 3 to 4% between the pertuzumab and non-pertuzumab arm. So I think in practice, I haven't seen any additional cardiac toxicity by addition of pertuzumab.
Dr. Karthik, what about you?
I also haven't seen any additional cardiotoxicity by adding pertuzumab, ma'am. But in trials, as I'm told, around 2 to 3% cardiac toxicity extra has been seen.
The reason what they explain is pertuzumab may lead to predominantly diastolic rather than systolic left ventricular dysfunction, and that's why addition of pertuzumab will not have much toxicity to the trastuzumab actually. So we'll move on. Now now we'll continue with the case. She had a 2D echo, baseline 63%. Given because it was old patient, I have given anthracycline based chemotherapy, and then now started on anti-HER2. Then we'd already discussed. Just I want to ask. Dr. Santosh, ki symptomatic and asymptomatic, you told already the percentage actually. And okay, next, she continued on that. Now she has ejection fraction of 50% at 6 months. What is the plan? If she is asymptomatic, what is the plan?
So this patient being diabetic developed a decrease in ejection fraction of more than 10%. From 62, it is 50 now. So a
12.
lot of cases, diabetics will have silent coronary artery disease. So matlab, we should exactly look out the decline in this ejection fraction. Does he have thing? I would send to a cardiologist explaining him. So there is a possibility that this drug will reduce this. The chances are maybe less than 5%. But are there any other alternative cause that causes a reduction in ejection fraction? So maybe if required, he will take a call doing an angio and see whether there are anything. If that is normal, then I would wait because there is no other alternative cause explaining the decline. Wait for some time, maybe 3 months, repeat an echo, see the improvement. Then if improved, then yes. So the challenge occurs when the patient develops a symptomatic heart failure. In that scenario, again restarting, the chance of developing again will be very high in case of symptomatic. If there is only decline of 10%, many cases we would be able to re-challenge, but symptomatic heart failures, the situation is little bit different.
I think Dr. Kinjal and Dr. Santosh already answered when to restart, when to start, and how to go ahead with this patient. Now we will discuss something else. Now cardiologist treated. Now this patient, same patient, she developed a skin rash. So Dr. Karthik, what is your experience? Do you have any experience about the skin rash on trastuzumab, and what type of rash you saw actually?
No, I haven't seen, ma'am, but infusion reactions I've seen
Okay.
with trastuzumab in a patient, and she subsequently developed in the next cycle also. So we couldn't give her a continued trastuzumab for her.
For infusion reaction.
Yeah, yeah, it was very severe, and then
And-
she got admitted in ICU and then came back.
So you never re-challenge her
Yeah,
actually.
yeah, yes, ma'am.
Okay. What about Dr. Nandita? Any skin rash you saw?
A few. Actually, I've worked in the UK for a few years and the large volume of patients on trastuzumab for a very long time. So I have seen a fair number of patients with skin rash, pruritic rash. And in UK, there's this funny situation where in neoadjuvant they get one brand and post surgery they get a different brand.
Okay.
And once that chemo stops and they go into the adjuvant part of maintenance Herceptin, surprisingly a lot of them started developing rash. So I don't know whether it was a change in the brand or just the fact that the chemo was suppressing it. But I would say at least 3 to 4% would have
Okay.
developed rash. We could manage them quite a bit on antihistaminics and emollients. 1 or 2 patients had to even discontinue
Literature says
treatment.
4 to 12%. Maybe depend on the things.
I don't think a lot of them report it unless it's really bad.
Yeah.
But in a trial, you're constantly checking, so it's always higher.
Yeah. Dr. Sujana Priya, anything you want to add about skin rash?
No, I'm actually, I just wanted to give a disclaimer. I'm a radiation oncologist.
Yeah.
So I should have done that before. So, but either way, yeah. I mean, I don't deal with systemic treatments anymore. So, yeah.
Dr. Kinjal, anything about rash? You saw any time in rash?
So in routine practice, apart from infusional rash, we have not seen the chronic rash as madam is seeing that they have seen in the UK. So not much experience with trastuzumab related rash.
Dr. Santosh?
One patient I've seen did not reoccur with change of brand. That is one thing. Our Indian patients do not complain of this hardly. If unless it's very pruritic only, we would, or else they would not report in many scenarios.
Any experience, Dr. Sadhvik?
Even I had seen only one patient, and then she recovered with antihistamines, so I could continue the drug. But yeah, very rarely do I get a patient complaining of a skin rash.
So I had 2 patients which were having rash, and the literature when I searched, it was erythema flagellate, the type of rash which they present with trastuzumab, and they have a different thing from acne form to the maculopapular rash. Like every things they can present like that actually. So now she had a disease-free survival of 15 months and now metastatic disease. So we started on TDM1 and then she is having epistaxis and low platelets. So Dr. Sadhvik, again, how many percentage of patient TDM1 in your practice you see that low platelets, they come with epistaxis and then you see them?
Thrombocytopenia, I've seen it very commonly with TDM1. I would say any grade thrombocytopenia more than around 55%. But epistaxis, quite less. Somewhere around 10% of the patient, they come with a bleeding complaint. But thrombocytopenia is very known documented side effect of TDM1.
Dr. Santosh?
So we see thrombocytopenia commonly and frequently. Maybe around 60% would have some amount of thrombocytopenia.
It is grade 1 to grade.
Yes.
I think
But that thrombocytopenia less than 20,000 or 10,000 causing epistaxis, I have seen in only one patient. Possibly it would be around 5 to 6% if we see.
Okay. Dr. Kinjal, how you treat this thrombocytopenia?
So regarding this thrombocytopenia, first of all, I would like to rule out the other causes of thrombocytopenia, whether it is some viral infection related or, and if it is ruled out, it is purely, if I am convinced that it is related to this TDM1 related, I would like to stop TDM1 till the platelet count is at least more than 75,000 to 1 lakh. And there is also off-label indication of giving some platelet growth factors to overcome with thrombocytopenia. Something like PDGF receptor agon.
Dr. Karthik, you will give something or you won't give?
Yeah, usually I give L-thrombopag.
So before the therapy to start or after finishing the therapy?
No, if the patient has symptomatic thrombocytopenia, I will.
So now you will give next cycle when the platelet increase to 1 lakh, you want to give with each cycle?
Yeah, I'll give with each cycle.
Okay. Dr. Sadvik, any opinion on this or change? You will add anything else?
I don't give prophylactic
Not prophylactic. In the patient who has grade 3 thrombocytopenia, first you will start and once it is increased, then what for increasing anything you give?
Off-label, yes, I use it. For next cycles and all, I make sure I repeat a CBP after between 5 to 7 days post-treatment. And if the trend is dropping again, then I again give. But I don't put it defaultly for every cycle for one episode of bleeding.
So across the trial, the grade 3 is something around 1.8 to 13% actually. So maybe in practice, I think we'll see a little more than this. But I don't know what is the reason why we see more, but this is there. Dr. Santosh, anything about transaminitis which on TDM1?
Transaminitis is the other thing we see. It would increase to maybe around in the range of 100 to 115 between SGOT PT, but they settle down until the next cycle. At the most, they require maybe few days of delay, but it did not trouble me too much to stop the treatment. So it's a known toxicity, but it would settle down and it would not cause a lot of treatment delays or stoppage of treatment.
So now she continued on and then now she again developed the breathlessness and the 2D echo is fine, like 58% is the ejection fraction. What next test you want to do, Dr. Sadvik?
The 2D echo is fairly fine, 58. TDM1 is also known to cause ILD. The percentage is very less, not as common as TDXT. So I'll be getting a pulmo consult and a CT chest.
Fine. Dr. Kinjal, what is your opinion on ILD associated with TDM1?
So the risk of ILD associated with the TDM is less. It is around less than 1%. I would say more than that, the newer agents still we have not used that, but the trastuzumab deruxtecan, which is the new coming agent in anti-HER2 armamentarium, it causes more of ILD, around 10 to 15% in the reported studies. So as my experience, I have not seen a case of ILD with TDM1 or only trastuzumab pertuzumab. But yes, this is one of the reported and the known toxicity, which should be kept in the mind while using these agents.
Nandita, Dr. Nandita, how is it in your practice, ILD rates and how you will treat them?
I don't think I've seen any with TDM1 and we haven't given enough TDXT to see as many patients. But I guess if a patient has ILD documented on a HRCT but is not symptomatic, you can just start them on oral prednisone 1 mg per kg, but if they're symptomatic, you admit them, give them high dose IV methylpred and then try to taper. And once they do get ILD, you have to discontinue the drug.
Correct. That is the...
You can't go back on it.
Yes. Dr. Sujana Priya?
Previous history of radiation should also be considered because radiation can also cause sometimes delayed ILDs. So that, not this bad, but that.
Yeah, you can tell about that, Dr. Sujana Priya. Anything you want to add? Because
Nothing. I mean, now that you have taken the route through the metastatic disease, I don't have much to say here. So, but either way, I mean, just as a, I mean, from the heart, I'm a radiation oncologist, so I would like to add a few things about what we are doing.
left-sided breast
Yes,
cancer, I
especially
think we'll
left-sided
ask
breast
about it.
cancers. We do a lot of techniques to spare the heart, and also nowadays we are contouring all the LADs, anti-descending arteries, to reduce the cardiotoxicity and other things. So, and I've never seen radiation causing that bad an ILD. Either if it causes, it will be the anterior most part of the lung, so where we do all the radiation part of the treatment.
Fine, thank you. Now, I think trastuzumab deruxtecan, nobody has access to that and nobody has used. So, but the percentage-wise, if you can see, compared to the drug which will be routinely used, trastuzumab and TDM1, the ILD percentage is very high. Grade 5, you can see here 2.2 and 0.8 in the Destiny trial. But till we use, I don't think so. How it will present in our practice, I don't know right now.
I've used deruxtecan in 2 patients. One patient had ILD after first cycle. The problem is the patient would be extremely sick. So we have a problem of infection versus this. We need to do bronchoscopy, do early, and initiate the steroids. Luckily, the patient improved. So, but matlab, it's a worry thing. We don't have any preemptive markers that to tell that patient. That
Patient's
is
going.
much more worrisome actually. We don't know what are those things. Some amount of renal dysfunction is a possible marker in clinical studies. They have showed that that patient might develop ILD, but we don't know exactly which patient develop. I haven't seen anyone with TDM1 related ILD, but TDXT, yes, one patient.
I think I have finished in my time. Any questions? Please welcome here. Anything, any comment from our panelists? Please tell us. Thank you, everyone. I think everybody bore with the toxicities what I discussed with that actually. Thank you very much. Thank you, my esteemed panelists. Thank you.
Now, moving on, I would like to invite Dr. Ekta Wala to discuss redefining treatment outcomes with immunotherapy in early triple-negative breast cancer. Dr. Ekta Wala is a senior medical oncologist at MediSquare Super Specialty Hospital, Ahmedabad. Thank you.
So for the next 15 minutes, I'll be discussing role of immunotherapy in the early TNBC. So I'll speak on background of TNBC and the rationale for the use of immunotherapy in combination with chemotherapy, and how clinical decisions are made in TNBC and how appropriate patients for immunotherapy in combination with chemotherapy are identified. See, we all know that breast cancer is first in terms of incidence and mortality. Even in latest 2022 data, 192 patients, 192,000 patients were new cases were identified, and with almost more than 50% mortality. And among them, majority cases, among them, the TNBC is the most responsible for high mortality because routinely TNBC, that accounts for 15 to 20% of the breast cancer, but in India, the prevalence is higher. That ranges between 27 to 35% of all the breast cancer patients. TNBC, we know that we see patients of TNBC at a younger age, they tend to be larger, they tend to be of higher grade, they tend to involve lymph nodes very early, and this TNBC have increased likelihood of distant recurrence and death as compared to other subset. So if we see the time to recurrence for TNBC, it ranges between 19 to 40 months as compared to 35 to 67 months of other subtypes. So here is a classification of TNBC. TNBC usually classified as basal-like 1, basal-like 2, luminal androgen receptor, mesenchymal stem-like, and immunomodulatory. So this immunomodulatory subtype, they have peculiarities of increased TIA infiltration. They show high CTLA expression, they show high PD-L1 expression, and that's why they are the subset where the immunotherapy is expected to work. So TNBC lack the high frequency oncogenic driver mutations, and that's why we have very limited molecular targeted agents. And because of that, we have so far chemotherapy is the main treatment option, but now there is a room for improvement, and with using this immunotherapy, our favorite weapon, the recent 2022 ASCO guidelines states that patients with T2, at least T2 or higher stage TNBC, the panel recommends the use of pembrolizumab along with chemotherapy, and this has now become the standard of care. We will discuss that trial in detail. Yes, multidisciplinary approach has proven to be effective strategy for individualizing therapy and better long-term outcomes. See, conventional NSCT regimen that is composed of AC followed by T results in a PCR rates of 35 to 45%, but in a keynote 522 trial, pembrolizumab addition of immunotherapy to chemotherapy was associated with PCR rate of 64% as compared to 55% without immunotherapy or only chemotherapy arm. So chemotherapy induces multiple immunomodulatory changes in the tumor microenvironment that may influence the effectiveness of immunotherapy. Chemotherapy along with immunotherapy leads to increased antigen release, upregulation of PD-L1, upregulation of immunogenic cell surface markers, and that's how it influences the response, good PET-CR with addition of immunotherapy. So these are the proven, beyond the routine benefits of preoperative systemic therapy, the main advantages as we discussed, the treatment response provides important prognostic information, and ultimately it identifies the patient with a residual disease where we can help them better by changing the molecule in an adjuvant setting. So this is the NCCN guideline latest version, the NCCN recommends that preoperative pembrolizumab along with carbopacli, followed by preoperative pembro along with AC or EC, followed by surgery and followed by adjuvant pembrolizumab is the standard of care. Now we'll see what are the high-risk subset of TNBC. The results of Keynote 522 trial demonstrated not only the benefit in the PCR rate, but also it has shown the improvement in the event-free survival. In the UK, a national prospective study showed that many centers opted for mastectomy over NST in almost 30% of patients with large tumor to breast size ratio, missing the potential opportunities for surgical downstaging, and probably in our setup it is higher than 30%. So now we'll have a detailed look in this trial. They have taken 1174 patients and they randomized this patient into 2:1 fashion to Keytruda versus placebo. For a chemotherapy backbone, they have taken paclitaxel weekly 80 milligram per meter square, day 1, 8:15, along with carboplatin either weekly or 3 weekly, followed by AC or EC regimen every 3 weekly. Then patient underwent surgery, and again in the adjuvant setting, Keytruda was given for additional 9 cycles versus placebo. The key inclusion criteria is where tumor size, if tumor size is more than 1 centimeter, then node should be positive, or if node is positive, then patient can be enrolled. The enrollment was done irrespective of the PD-L1 status, And key exclusion criteria were autoimmune disease or if medical condition that required immunosuppression. So the primary objective was PET-CR rates and EFS, and the additional efficacy outcome measure was overall survival. So this is the detailed design as we discussed. If you see the baseline characteristics, majority of the patients, almost 3/4 of the patients were of stage 2 and only 25% patients were of stage 3. So this has become the dictum that if patient is having PET-CR, then it is associated with a better overall survival. A meta-analysis of 52 studies published from 1999 to 2016 globally was carried out and which evaluated a total of 27,000 patients. And this analysis revealed that those who had PET-CR compared to those who had not, significantly better overall survival was there with patients with the PET-CR. So in TNBC also the 5-year EFS in the patients with PET-CR rate, with PET-CR subset, 90% versus 57% with those patients who had not PET-CR. So in this trial, PET-CR rate was 64.8% as compared to 51.2% favoring the pembrolizumab plus chemotherapy combination arm. And the PET-CR rate advantage was rather better with the node positive patient as compared to node positive, node negative patients. So the absolute advantage was 20% with in those patients who had node positive. At the time of interval analysis, after 18 months, EFS in the pembrolizumab group was 91.3% versus 85.3%, and that is too statistically significant. So overall, the number of patients with an event was 16% with Keytruda plus chemotherapy versus 24% with placebo plus chemotherapy. So it shows that the hazard ratio is 0.63. So it means that overall 37% reduction in the risk of event by addition of immunotherapy to the chemotherapy arm. So overall, almost all the subsets were benefited, including PD-L1 negative subsets were also benefited with the immunotherapy addition. And if we see the side effect profile, then yes, with addition of immunotherapy, there were more diarrhea, rash, pyrexia, anorexia with the immunotherapy plus chemotherapy arm as compared to chemotherapy only arm. So when the updated analysis at 36 months was done, it was showing 84.5% EFS advantage at the 36 months as compared to 76.8%, and it was statistically significant. But yes, still we are waiting overall survival data. It is yet immature. So we have data for other immunotherapy also. For atezolizumab, atezolizumab was tried in IM patient 031, where 333 patients were taken. Atezo was given every 2 weekly. To the chemotherapy arm, in the backbone, they have taken weekly nab-paclitaxel, followed by dose-dense AC. That showed increased PET-CR rate from 41 to 58%, irrespective of the PD-L1 status. But this trial was not powered to comment on EFS. Then Atezo was tried in other trial, where Neotrip is the another trial where Atezo to nab-paclitaxel carbo on day 1/8 every 21 days was tried, but this trial has shown no PCR advantage. Similarly, durvalumab was tried in Japan Nuvo trial, where they have taken 174 patients only. In this trial, they have taken clinically 1B to clinically 14 A2D patients, triple negative. Patient received 1.5 gram durvalumab every 4 weeks, added to the nab-paclitaxel weekly for 12 weeks, followed by durva or placebo every 4 weeks plus EC or AC regimen every 2 weeks. And surgery then was done, but durvalumab was not continued after surgery. See, primary objective was PET-CR. And secondary objective was invasive disease-free survival, distant disease-free survival, and overall survival. Addition of durvalumab increased PET-CR rates in all the patients, PD-L1 negative or positive, but it was a numerical advantage only. It was not statistically significant. But when subsequent reporting was there, at a median follow-up of 42 months, The addition of durvalumab improved 3-year invasive disease-free survival as well as improved distant and overall survival also, irrespective of the window treatment with durvalumab or not. So the overall survival was 95.2% versus 83.5% favoring durvalumab arm. But yes, durvalumab and etizo, they have yet not approved because the sample size of this trial was very low as compared to the sample size of Keynote 522 trial. So these are the ongoing trials with the different regimens in a different manner in a neoadjuvant setting. So these are the this is the comparison of different immunotherapy trials. So in Keynote 522, they have given pembrolizumab to all the patients for 1 year, irrespective of the PET-CR or not PET-CR. Pembrolizumab was given along with radiation, or it can be given post-radiation also, but capecitabine was not given in this trial. So this is the hypothetical case I am presenting here just to highlight the immune-related toxicity with immunotherapy, because we want to safely hand over these patients to our surgeons. So this is a young lady with clinical diagnostic stage was stage 2, presented with stage 2B TNBC. As discussion in multi tumor board discussion, as per discussion, patient received 4 cycles of Keytruda plus carbopacli followed by 4 cycles of Keytruda plus AC was planned, but after 12 weeks of NSCT, patient had abdominal pain and diarrhea. So diagnosis was grade 2 immune-mediated colitis, and Keytruda had to withhold, and then she was placed on corticosteroids and symptoms subsided and improved to grade 1. Corticosteroids were then successfully tapered over 1 month, and again Keytruda was reinitiated. Then definitive surgery was planned. Baseline blood cortisol was checked. After 5 weeks after last NSCT lumpectomy, surgical axillary staging done, and it was showing PET-CR, and after that pembrolizumab was started in the adjuvant setting, similarly as done in Keynote 522. So 3 months into the adjuvant treatment, she experienced again the symptoms of fatigue, lethargy, and cold sensitivity. TFT was done, and it was showing low free T3 level and high TSH level. So the diagnosis was grade 2 immune-mediated hypothyroidism this time. Patient was started with thyroid replacement hormone and again continued on Keytruda. So we have to be very careful while prescribing or while continuing this immunotherapy, because early screening, and if we can detect it, the immune-mediated toxicity at earlier stages, then it can be managed very smoothly. So to conclude my talk, that ESCO also recommends now using pembrolizumab in this high-risk stage 2, stage 3 patients. And if we see the NCCN guideline, it has also started it has also shown that pembrolizumab along with carbopacli followed by AC or EC with pembrolizumab is a standard of care. But still there are some questions that are unanswered. The one question is, should adjuvant pembrolizumab be administered concurrently with other adjuvant therapy in patients who fail to achieve PCR? Example, like either with capecitabine or olaparib in the patients who are also positive for germline BRCA mutation. So the answer, we don't have the data. One can combine, but we don't have the data. In some studies, they have shown that pembrolizumab can be safely combined with capecitabine and olaparib. But yes, NCCN recommends to continue adjuvant pembrolizumab only if it has started in a NSCT setting. If it is not given, then one can continue capecitabine or olaparib according to their indication. The next question is last 2 minutes. Will the addition of pembrolizumab also improve outcomes in the patient treated with different NSCT regimen? Because they have used anthracycline based regimen, but suppose a patient is having contraindication to anthracycline, then can this data be extrapolated? Again, we don't have the data, but yes, we can use pembro in those patients where the anthracycline cannot be used. And the third question is, should the adjuvant pembro be used in the patient who did not receive it concurrently with NSCT? Suppose a patient comes after surgery and it is stage 3, then one can extrapolate data and use pembrolizumab along with chemotherapy. So thank you. So I would like to invite any questions.
With neoadjuvant, pembrolizumab we can continue because in data 522 it has shown that even the patient who did not get the PET-CR but who received pembrolizumab did better. Number two, different chemotherapy aspect along with the neoadjuvant chemotherapy. If there is any certain contraindications like anthracycline, patient is the cardiocompromised, then we can definitely use another chemotherapeutic. It is out of 522, but it has been mentioned in a metastatic setting. We will discuss in panel discussion. And what is your third unanswered questions? No.
Post.
Yeah, if it is not given neoadjuvant, then there is no role of the adjuvant pembrolizumab.
So we don't have data for any of these questions, but we can extrapolate. And even in
It was
NSCT
study.
setting,
It was study. I forgot the name. It was keynote. I think 012 study in which the adjuvant pembrolizumab has been used in TNBC. It's a very small size of the sample and it's a phase 2 study. It's a failed study, so we are not having any positive data which shows that the pembrolizumab they can be used in adjuvant setting if it has been not used in new adjuvants.
and even in this NSCT setting, we don't have yet OS data. So we are waiting for the OS advantage so that we can use Pembro with more confidence in our routine patients. Thank you.
Now, let's move on to our last session. For that, I would like to call Dr. Kaushal Patel.
Yeah, thank you. And I would like to invite my panelist, Dr. Kajal Shah from Ahmedabad, Dr. Maitri Gandhi from Ahmedabad, Dr. Shruti Goyal from Vadodara, Dr. Sujana Priya from Hyderabad, Dr. Viswajit Rai from Bangalore, Dr. Raghuram from Hyderabad. Yeah. Any panelist left out from list? Yeah. Fine, thanks. So Dr. Ekta Mek, my panel is discussion is very easy. She has covered TNBC neoadjuvant aspect. We will discuss our practical aspect and clinical scenario during our practice. So my first question, how much of your patients they are TNBC in your practice? Starting from first.
Around 40-45% of my patients are TNBC.
Out of all
Out
breast
of all the breast
malignancy.
cancers,
Yeah.
which I see.
Any 40%,
Yeah.
right? Any difference of opinion? It's quite big. Very big. And yeah. So any other things? Any other?
We have 30%.
So approximately 15 to 20% of the patients who are TNBC in our practice. And how the future of those patients? How much of your TNBC patients in early stage after treatments go in progression or metastatic, and what is the probable survival of such type of the patients?
I say the first 2 years is where the maximum recurrences happen, and most of the time it's visceral metastasis.
So approximately out of 100, how many patients
35 to
will get?
45%.
45%.
Yes, and depends on the stage again.
Yeah. Average
high nodal positivity, there's a very high chance that they recur in the first 2 years. Early stages we've had TNBCs because in Bangalore we do get a lot of early T1s and TNBCs, so they do pretty well. But TNBCs with high nodal positivity very bad.
Right. Any difference? Any recurrence rate? 45%. All agree. Average, irrespective of the stage. And what is overall survival of such type of the patients? Stage 1 and stage 3.
5-year survival?
Yes.
5-year survival for stage 1, I would say about 75 to 80%.
Okay.
And stage 3 is about 35 to 45%. less than 50%.
Right. Dr. Kajal, your opinion?
TNBC stage 1 will survive around 75 to 80%.
Stage
And-
1. Yeah.
And stage 3 will survive around 35 to 40%.
Right. Dr. Shruti?
Similar numbers.
Similar. Okay, fine. So this is the TNBC will have a recurrence approximately within 2 years, whatever it is. And we can say the 3-year survival rate depends upon the recurrence is approximately 20 to 25%. So it's a very bad malignancy, we can say. The chances of the recurrence is high, survival is very less, and options of the treatments are also very less in advanced stage. So if we see the patient, suppose if we have patients with TNBC directly with the medical oncologist, very less likely in our practice, but it's came directly to you with a T2N0M0. Tumor size is approximately 2, ERPR negative. Now, what would you like to do? Dr. Kajal?
We generally discuss a patient with tumor board and patient tumor size more than 2 centimeter with node negative.
Right.
Then we ask for the neoadjuvant chemotherapy.
Okay.
And,
And suppose tumor size is 1.5 centimeter, node negative, ERPR negative, then?
Then we discuss about the upfront surgery,
Upfront
either
surgery.
breast conservative or modified radical mastectomy.
Okay, fine. Any other biomarker either on biopsy or on blood would like to do before starting any treatments in form of the chemotherapy or in form of the any neoadjuvant treatments?
Generally, we ask to patient to do PDL1 and miss BRCA1, BRCA2, and if possible, we ask for NGS also.
Right. Dr. Shruti, any role of Ki67 in our practice in TNBC particularly? Is
So
there
it will
any such type of the things like high Ki67 with TNBC did do bad compared to the low Ki67 with the TNBC do well compared to
So
high?
that would be our general understanding, but the Ki67 will not determine the treatment, sir. So we want to get that information, but that does not change anything, sir, in terms of treatment.
Right. So, Dr. Priya, any difference in neoadjuvant setting? What is your criteria to start the neoadjuvant chemotherapy in TNBC?
Yeah, like Dr. Kajal was mentioning before, and as per the guidelines, since we've been hearing since morning, so more than 2 centimeters node positive, it's a high risk subtype. It's better to go with neoadjuvant chemotherapy or neoadjuvant chemoimmunotherapy.
Right.
So
And-
that will determine the biology of the disease if you have a PATCR or not, and it will further determine your adjuvant treatments.
Right. So Dr. Kajal has mentioned PDL1 over biopsy. A few laboratories nowadays with us who will do the PDL1 from the blood, except foundations and CMI. So are you agree that the PDL1 positive or negative will help us to decide the neoadjuvant chemotherapy in TNBC?
No, I don't think.
So in other way, any other biomarkers would you like to do over the biopsy specimen before starting treatments? Any of the NGS biomarker or anything else?
I mean,
No. No, it's early. We will discuss metastatic later on, next session. So no markers, we will go.
Except for the BRCA, what you
Yeah,
already mentioned.
suppose patient is BRCA1 positive, TNBC, tumor size is 2.5 centimeter, node negative. What to do? Is there BRCA positivity make any difference in the neoadjuvant chemotherapy setting now in 2024?
I don't think there is any difference of
Yeah.
adding
So,
anything
in
extra
short,
except that.
there is no marker required to be tested before starting neoadjuvant chemotherapy in TNBC. That's a fix. So, patients came to us, you have a planned neoadjuvant chemotherapy. Anybody? Dr. Vishwajit, what is your regime of the treatments?
It again depends on various factors. Of course, we do offer the use of initial immunotherapy, chemoimmunotherapy in all our triple negative patients. But if they are affordable, we do go ahead with, and we've had fantastic results with addition of chemoimmunotherapy. but at HCG Bangalore we see two extremes of patients who can afford, and then the other extremes who can't. So in that situation we'd go ahead with the traditional AC followed by taxane.
Okay, suppose if patient is affordable, you started with the immune therapy, pembrolizumab. What is your regime of the treatments? How frequently? What is the dose? Because Keytruda is given to be 21 days. So now your questions come to you. What is the chemotherapy drug combinations and at how much intervals?
Had it been without immunotherapy, I do offer dose dense regimen, but when adding Keytruda, we do obviously have two options. One would be either to do a paclitaxel on a weekly basis or go ahead with a 3-weekly basis. Both options are open. Medically fit patients, we do go ahead with 3-weekly.
Right. Dr. Shruti, what is the next? 4 cycles pembrolizumab plus pacli plus carbo followed by?
Sir, 4 cycles of AC or EC, 3 weekly with 3 weekly pembrolizumab.
Yes, so that is the difference coming to the pictures. Usually we are using dose dense AC or EC along with the paclitaxels. Now it's a 21 days gap. Are you comfortable to complete the whole cycles of the chemotherapy along with the immune therapy before surgery, or you would like to send the patients in between for the surgery?
So we generally complete the regimen before surgery at our institute.
Yeah. So Dr. Priya, any difference of opinion? Would you like to complete the chemotherapy plus
No,
immune
there is no
therapy?
difference of
Yeah.
opinion.
So you will complete
Finish
the
the
whole
systemic
treatments
treatment.
together.
Yes.
Approximately 6 months, then send the patient for
Send
the
the
surgery.
patient for surgery, correct.
Fair enough. So, did you use, anybody has used the immune therapy or Keytruda in neoadjuvant setting in TNBC? Anybody has experience clinically? Yeah. So how is your experience with in view of the result as well as in view of the side effects?
Most patients have done well. I say I would have used about 4 to 5 patients on pembrolizumab immunotherapy. 3 have attained PAT-CR. One had we had a very tough time. This patient actually went into immune myopericarditis. She came with massive pericardial effusion causing tamponade and was in the ward for a very long time. So, one of those extreme bad immune adverse events we had in this one patient. After that, otherwise it has been fairly easy regimen. But the same patient who had immune pericarditis, that was after 3 cycles, we were not able to give any further chemotherapy. She had a PAT-CR.
Right. So did you use pembrolizumab in any other indications apart from the breast?
Yes.
Yeah. So did you observe any difference in the breast with the Keytruda compared to the other, like lung, head and neck, or RCC, or any other indications? Did you see any difference in view of the side effects, particularly? The patients who are having breast malignancy, they are developing more side effects with the Keytruda compared to the other malignancy. Did you see or did you observe in this your practice?
Not really. When used in RCC, most of the problems is because of the axitinib component rather than pembrolizumab. Lung also we have not had major problems.
Yeah. So in other way, we can say that the patients with the breast malignancy, they are facing more side effects compared to the other malignancy.
Nothing.
Nothing. Not in your case. What is your adjuvant plan of the treatments? Patients complete 4 cycles of the chemotherapy with Keytruda, another 4 cycles of the chemotherapy with the Keytruda with very good response on the CT or PET CT scan. Patient went to the surgery. Now, what is plan of the action?
Yeah. It again depends on the adjuvant treatment. Definitely we give pembrolizumab maintenance. Then we also, most about 30-40% of the triple negatives are BRCA positive. After completion of pembrolizumab, we also offer adjuvant olaparib if there's a germline mutation. Unlike where we don't, unlike the traditional where we give capecitabine, I don't use capecitabine if patient has not had a PAT-CR on pembrolizumab. It is only continuation of pembrolizumab.
Dr. Shruti, patients completed whole chemotherapy plus IO, went to the surgery. Patient did not get pathological complete response. Patient is BRCA negative. And patient has node positive initially as well as post surgery. Now, what is plan of the treatments?
And
Sir,
how you
so-
overlap the Keytruda along with the radiation therapy?
Sir, we can continue along with radiation. So we will start adjuvant pembrolizumab along with radiation. In terms of whether to add capecitabine or not, we do not have data. But as we have all discussed that it's an aggressive biology and we would want to give the benefit of doubt. So we would add capecitabine along with pembrolizumab, sir. So that's what I would do.
Yeah. Dr. Raghuram, if patient is...
One thing I just wanted to add that pembrolizumab, of course, we can continue with radiation, but not capecitabine. So that we would prefer after the completion of radiation.
Fair enough. Because now we have data in cervix also, A18, where the chemotherapy plus pembrolizumab plus radiation therapy as a curative intent. Anyways, Dr. Raghuram, patient is BRCA positive.
And patient has not achieved PAT-CR. BRCA positive, non-PAT-CR.
Whatever it is, received, achieved or not. Now,
If
what
it's
is the
PAT-CR,
plan?
I'll continue with Pembro. If it is non-PAT-CR, as sir has stated, there is no data suggesting I can add olaparib, but given the benefit of doubt and being an aggressive disease, I would be more comfortable adding olaparib along with pembrolizumab.
So patient is BRCA positive, achieved PAT-CR, so you will continue with the pembrolizumab. And if it is not, then you will add olaparib along with the pembrolizumab.
Yes.
Technically, yes.
Yes.
Why not in PAT-CR patient?
After achieving PAT-CR, the benefit of olaparib again is questionable. So
Even in not achieved CR, it's also questionable because we don't have any data with the pembrolizumab plus olaparib in BRCA
yes,
positive
that's what I'm
patients.
saying. There's no data per se, but being
Yes.
an aggressive disease, extrapolating, I would suggest to the patient.
So why
I'm
not
not saying
in,
there is data.
why not in PAT-CR patients? There may
PAT-CR,
be-
there is no benefit in PAT-CR patients adding olaparib.
So there is no chance of the recurrence in PAT-CR patients.
There is. I'll add it at the time of recurrence.
Anyways, so it's still, there are lots of questions unanswered as mentioned by Dr. Ekta in her presentations that in early breast malignancy with the neoadjuvant setting, there are lots of questions are unanswered even after the completion of the treatments. So the patients completed the total cycles of the pembrolizumab in adjuvant setting. Now, after 2 years, patients develop liver metastasis. Repeat biopsy was done, it is TNBC. PDL1 was done, it is 90%. Now what to do? Dr. Kajal? Say not 2 years, but 8 months. I will make questions little more difficult.
If a patient previously tolerated pembrolizumab well and not have major side effect, grade 4 toxicity, we can re-challenge with pembrolizumab as PDL1 with more than 90%. And according to Keynote 355 trial, we can add chemotherapy to pembrolizumab to get a better response.
So even in 8 months of the relapse, you would like to add pembrolizumab. Anybody would not like to add the pembrolizumab in this particular subset? Or would like to add? So we completed neoadjuvant early breast TNBC. Now we are coming into the metastatic TNBC. This is little bit easy because we have very long-term data with the. I would not give because the patient is only 6 to 8 month PFS. So I think it is not, there is no sense of giving pembrolizumab in the particular. This patient anyway it will do the poor. Yes, we will discuss in this metastatic setting. We must nowadays in 2024.
Also, just I would like to add that there is the cost benefit ratio also we have to keep into account.
Yes,
if
yes,
it's recurring in 8 months with the same drugs, then why
Yes.
to again consider it?
And NGS not only to decide which drug will be effective, but it is also to decide which drug is not effective because there are certain mutations are there in a tumor. In presence of that, the immune therapy will not work. So it is also important at this moment to see NGS and decide which is important for us, effective as well as not effective. So, yeah.
So actually, even the pharmacodynamics also say that once the receptors are saturated by immunotherapy, they will stay saturated for 8 to 9 months. So as you said that if it has recurred within 8 months, this immunotherapy is already in the system, so it would not make sense to re-challenge now that you said.
Yeah, that is one thing. And another thing is that if see clinically and practically, it is free after I think 5 cycles nowadays. So we can anyways use if patient is not getting any side effects in this particular set. What advantage the patient is getting from such type of the things we are not aware. Practically and clinically, if 6 or 7 months of the DFS, then there is no sense of repeating the same drugs at that moment. So one 53 years old lady, she has been detected with the triple negative breast cancer, and she has approximately T2, N2, M0 triple negative, received conventional anthracycline, taxane chemotherapy, and she was BRCA negative. And completed her treatments, including the neoadjuvant chemotherapy, surgery, radiation therapy, and capecitabine also up to 18 months of after post surgery. And then patients develop metastasis, lung mets, liver mets, bone mets. And patient biopsy once again confirmed that the patient is triple negative. The PDL1 status was positive. Now what to do? Kajal, Dr. Kajal?
Disease-free interval?
It's 18 months. A patient has not received any immune therapy in her previous treatments.
So I think patient is affording and financially afford the immunotherapy. We can advise about immunotherapy with chemotherapy.
Right. Dr. Maitri, your opinion?
I think that's the same.
Anybody would not like to use immune therapy except financial crunch. All would like to. Starting from the first, which drug combination would you like to?
I would use Keytruda, pembrolizumab along with the taxane.
Second.
Again,
Taxane has been used previously, approximately 24 months before, 2 years.
what about
in-
atezolizumab?
Okay, next.
Pembro with taxane, sir.
Okay. Dr.
Pembrolizumab with taxane.
Okay.
Apart from pembrolizumab with taxane, the only other combination that has shown good result is again pembrolizumab with eribulin. Apart from that, there's no other data. Atezolizumab, though, was initially approved in the metastatic setting because of lack of PFS benefit. The approval was withdrawn. I think this is the best option that we have.
Anybody would like to use durvalumab? There is good data has been shown by Dr. Ekta. Anybody has keen to use in this particular subset?
No.
Any specific reason not to use?
Our experience with durvalumab both in lung and BTC has been
not good.
Yeah.
Let's try and breast. So a durvalumab study was there, but there are two fallacies in this particular study. Number one is the number of the patients which has been included is very less. And number two, there is no any OS advantage has been documented till now. So OS is not matured yet. So we have to wait some period of the time till the durvalumab has been approved in breast TNBC in metastatic setting also.
Dr. Kaushal, would you do a BRCA at this point before
It was done, it was negative.
It was negative. Okay,
Yes,
sorry, I
it was
missed that.
done, BRCA1, BRCA2 was negative. Yes. Yes, so initially PDL1 was negative. Now patient has been detected with the PDL1 positive. Suppose patient don't have any tissue, then what to do? There is problems with the biopsy, or whatever the amount has been received in the biopsy is inadequate to detect the PDL1. Patient's initial sample is with us, but it was not tested for the PDL1. Will
I
you
think
like
to
to
use in the metasetting we don't need a PDL1 status as such. You can use it the approval is irrespective of PDL1 status.
No. In TNBC, it is required to be PDL1 positive. In NACT, it is not required to be PDL1
In
positive.
metastatic you need
Yes.
it.
So, Dr. Kajal, would you like to do the PDL1 testing from the initial sample when patient was detected with the breast malignancy 2 years back?
Generally, we advise PDL1 in metastatic side,
Right.
if possible.
Yeah. So if it is not, then we can do. If it is possible to get the new sample, and if it is possible to do the PDL1 in metastatic site, then it is best. But if it is not, then we can do the previous sample when the patient was went for the surgery. So this is the combination which has been used in 355. nab-paclitaxel, paclitaxel, gemcitabine plus carboplatin. Whenever the PDL1 is positive, the patient is getting more response and results. Now, these are the things which we discuss is the effect and survival. Now, what are the side effects are you facing in your practice with the pembrolizumab or any immune therapy drugs? That is major concern for you while using this drug in your practice. Starting from that.
Most common I see is hypothyroidism. Okay,
Right.
many times, though they don't have symptoms, we see the thyroid function test over a period of time showing abnormalities. As per Western literature, the most common side effect they say is dermatitis, but in Indian population we don't see much. And with Pembro, as I said, a couple of serious adverse events. One was immune myopericarditis, which was quite severe, and one patient with colitis.
Right. Dr. Kajal, any specific side effects or any major side effects are you facing using Keytruda?
Major side effect we are facing is hypothyroidism followed by colitis. One patient developed severe encephalopathy, so we have to withhold the pembrolizumab.
Right. Dr. Maitri, any opinion of pembrolizumab?
No, I'm being a radiation oncologist. I'm not much exposed to that. Sorry.
Dr. Shruti?
Actually, not very worried about the side effects, sir.
Okay. Dr. Priya, any concern of side effects?
Dr. Maitli, so I'm a radiation oncologist. So.
Dr. Last.
No, sir, overall it has been a fairly well-tolerated drug. Hypothyroidism, mostly it's managed with a pill. Rarely in my practice I've seen immune colitis, and dermatitis, as sir has told, hardly I've seen any.
Yes, yes. So in our practice in Indian patients, it is well tolerable drugs, we can say. Compared to the Western documents, we are getting very less side effects, or we can say it's a good drug to use in our practice. I have my observation that in breast cancer, there are a little bit more side effects with the pembrolizumab compared to the other cancers, other like lung or head and neck or RCC. But anyways, it's my personal experience, and I'm collecting the data on that. But anyways, thanks for all my panelists. Thanks, Dr. D.G. Vijay sir, for inviting me to discuss. Thank you.
Thank you all. We are done for today. I would request you all to please assemble at the reception by between 6:15 to 6:30. 6 to 6:15. Okay. Between 6 to 6:15, we'll be heading towards our laser show at Statue of Unity. And for tomorrow, we'll start our session at sharp 9 a.m. and the registrations will start at 8:30. Thank you.